Many efforts have been done to interface the human eye with the machines in a seamless way, and much progress has been made in this field. Innovations like eye tracking were present as early as the 1980s, and now even more practical and advanced technologies are being integrated into this
Many
development.
efforts have been done to interface the human eye with the machines in a seamless way, and much progress has been made in this field. Innovations like eye tracking were present as early as the 1980s, and now even more practical and advanced technologies are being integrated in London. Many efforts have been done to interface the human eye with the machines in a seamless way, and much progress has been made in this field. Innovations like eye tracking were present as early as the 1980s, and now even more practical and advanced technologies are being integrated in London. Many efforts have been done to interface the human eye with the machines in a seamless way, and much progress has been made in this field.
To learn more, visit our website, ocularinterface.com.
Hello, everyone, and welcome back to Vision Science Academy platform. I'd like to congratulate the World Optometry Day on behalf of Vision Science Academy team, Dr. Shroff Eye Hospital, and also Delhi Optometrists Association. And also, thank you all for your hard work and commitment towards patients' eye care. And also, Happy New Year to all my Persian and Zoroastrian colleagues. Let's not just waste time, and I'd like to introduce my first speaker, Miss Sonia Srivastava. She's the faculty optometrist and in charge of Vision Enhancement Center and clinical training and at Dr. Shroff's Charity Eye Hospital. She has experience of 25 years in the field of optometry. She has completed her graduation in optometry and fellowship in LV Prasad Eye Institute, where she received the Best Fellow Award for the year 1999. She leads the Vision Enhancement Center, which was developed in 2001 with an objective of serving the visually impaired group and improving their quality of life. She had been chosen as a national focal person for NFP course by the Hong Kong Low Vision Society in 2014, and she has also led the National Low Vision Project under Sight Savers in 2012 to 2015, where the objective was to establish and strengthen 21 low vision clinics in eye hospitals in different cities that doesn't have the service across the country. Let us welcome Miss Sonia.
Thank you, Sophia. Should I start my presentation? So I'm just sharing my screen. Thank you.
Sure. Yeah.
Is my screen visible?
Yes, ma'am.
Yeah, so can I start it?
Yes, we are waiting.
Okay, thank you. Thanks to very warm greetings from me, and I'm very thankful to Vision Science Academy who has given me this opportunity for this platform to talk. So I would just begin my presentation of low vision with a definition of low vision, which WHO has been given. A person with low vision is one who has an impairment of visual functioning even after treatment, surgery, or best correction, and has a visual acuity of less than 6/18 to perception of light, or visual field of less than 10 degrees from the point of fixation, but who is potentially able to use vision for the planning or execution of a task. If we see a globally data of magnitude of visual impairment, and there's a graph shown over here where the blue bar represents the data of 2002 and the brown bar shows the data of 2010, which is almost double. And as we know, the cataract and uncorrected refractive error are the major cause of visual impairment globally. If we exclude both the areas, then still the 50 million people require low vision services across the world. As far as the visual impairment categorizations, low vision is further divided into three categories: moderate low vision, severe low vision, and profound low vision from the visual acuity perspectives. And the blindness is near total blindness and total blindness. In India, as per RPWD Act, like Right of Person with Disabilities Act 2016, our definition has been revised of blindness. So when the visual acuity is the less than 3 by 60 or total absence of light or limitation of field less than 10 degree in the better eye is being said to a person is blind, and a low vision is person visual acuity not exceeding 6 by 18 to the limitation of field less than 40 to 10 degrees. So these are the criteria which has been set, and the new matrix of visual disability also is being issued. So as it's easier to calculate the percentage visual disability, and as per the percentage, a person can avail the various government benefits also for the same. So there are many causes of low vision. If you look at in children as well as in adults, the commonest causes I would be briefing it over here: it's albinism, aniridia, corneal dystrophy, congenital cataract, high refractive error, hydromacular degeneration, congenital glaucoma, microphthalmos, ROPs, most common in children. Even sometimes children are coming with secondary optic atrophy also, post clavicular meningitis or brain tumor. In adults as well as ARMD is a major cause of low vision. Entire world also, in India also, apart from the AMD, glaucoma, optic atrophy, diabetic retinopathy, and RP also the major cause of visual impairment adults. As far as the vision loss is concerned, we have seen many diseases are causing different types of losses, but that we can categorize in three divisions: central vision loss, peripheral vision loss, and overall blurred vision. So when you have a loss of central vision, it basically happens because of macular degenerations. The people are finding difficulty in reading prints, doing writing tasks, recognizing faces also being difficult, and color vision also a major issue for them. Whereas the loss of peripheral vision, which happens in retinitis pigmentosa and glaucoma, unable to perceive the people or surrounding. They have a difficulty in unfamiliar environments, bumping into peripheral objects, and major difficulty they feel is mobility, navigation, and driving. Overall blur vision, which happens in corneal scarring or as a cataract haze, they have a reduced contrast. Glare is a major issue for them, blur vision, and they have a difficulty in perceiving the sharp details of the object. When you see that low vision children or adults, there were different kind of challenges we faced. So when we talk about the pediatric age group, the parents are being very disappointing when the child is having low vision. The main difficulty or challenge they face during for their education and academic career opportunities are little less for these children. They feel the child is being dependent on them. And of course, that availability of resource materials also is a major concern for them. Whereas we see if we see the older age people with low vision like ARMD or diabetic retinopathy, they have a limited life expectancy. So they are mostly in the phase of denial of taking these services. Affordability is also issue. Reduced opportunity for communications, and since these individuals carrying multiple systemic problems too, so follow up with that is not very easy in the clinics. So most of the patients when they come to the clinic or visual impaired people having a lot of psychological factors. They might be in the phase of denial or anger, and if they've accepted it, they might be a phases of depression they have. So goals of a low vision care in the clinic when the patient is in, it's very important to educate patient on eye condition, help them to understand the availability options for them and how they can utilize it and they can use it, whether it's a glasses or low vision devices or new technology which is in or community resources. We need to educate parents and teachers and professionals also. It's a comprehensive approach, and we need to refer these children and adults for further appropriate intervention also. So during the part of assessments, with this low vision examination protocol, we will start the history and health examination, refraction, and followed by other visual function tests. On the basis of that, we make some decisions and recommendations to the person. Starting from the history, and history is very important for all the age group, especially the pediatric group, where you need to understand what kind of diagnosis patient has. Is it a progressive disease or stability of vision is there? History, any history of consanguineous marriage. So accordingly, you can plan for genetic counseling also, general health issues, any other impairment apart from vision if the child has. Schools or academic status needs to understand the child is in a mainstream or special schools, what kind of work pattern the child is being given, is there any facility of special educator in the schools, or the school staff is being cooperative enough to take care of the child's academic issues. Class settings, types of placement of light, sitting position, everything need to understand. Accordingly, you can rehabilitate a child properly. Whereas in young adults and adult patients, the specific information related to their reading requirements and desires, what kind of daily living skills which is being affected them more, is there anything which is difficulty them to do it, intermediate activities like signing check or maintaining accounts, is there any use of computers or drivings or other activity which it is being hampering because of the visual impairment, needs to know. After a brief history and doing to know the specific information, we're going for vision assessment. In children, we do vision assessment informally also. So we can observe the reading materials of a child is being using in the classroom. And for the formal assessment, of course, one has to go for ETDRS logMAR chart, and for a preschooler's Leah symbols chart. Similarly, we just need to note down the near vision acuity too. So we need to use appropriate vision charts. We should know the lighting levels or the illumination level a person is being comfortable, or assessment of visual skills also is important, because it happens in central scotoma patients. The person is not able to read comfortably as the scotoma hinders the smooth reading. Visual functions needs to be assessed apart from vision, refraction, ocular function test, cover test, motility, visual field examination, color vision, contrast sensitivity, and of course functional vision. After all the assessment, we make some management on the depend on that. So the major part is management of these children, enhancing vision, and we should make them maintaining independence and enhancing the quality of life. These three are the major components while rehabilitating these patients. So management in terms of magnification, right? So we just need to put some calculations and trial of devices. The key features while doing the calculation and trial of devices, the level of magnification, it should be a working distance comfortably, testing the patient's ability that he can manage his own reading materials or no. Selection of devices is important as they can handle it very well, improving the lighting conditions and contrast. There are many low vision devices which is being available. We can categorize in optical devices, non-opticals, electronic devices, audio devices, and different kind of software also available for these individuals. There are many devices for distance. Most commonly acceptable device by children are telescopes. It could be a spectacle mounted telescope, it could be a handheld, or it could be a clip-on. So depending on the age and handling of a child, we're prescribing accordingly. There are many other devices for near are spectacle magnifier, stand magnifier, handheld magnifier, which all comes with the illumination and non-illumination forms. Bar magnifiers and dome magnifiers, pocket and sheet also be acceptable by this individual depending on the need of the task. Apart from the optical devices, many non-optical devices also have these individual or children to help it, like reading stand, which basically gives a comfort for the reading postures, lamp for good illumination and contrast, letter writing guide to write in a straight line, filters to avoid glares, bold line notebook for the writing purpose, typoscope to reduce the glare and reading them in a straight line. These are the main photographs of few children who are using the devices comfortably after giving them a proper training. For adults also, we just need to understand that what kind of device they will be comfortable in terms of handling and in doing their own task. So as we are going to a new era of low vision, of course, apart from the optical, non-optical devices, there are many new technology which is being in for these individuals. So I would just like to brief of a few points over here. Over a period of time, training in low vision rehabilitation also being improved. And in India, many of the institutions are being referring to the trainees. So many of the optometrists who are coming and taking this field and serving the needy individuals. Awareness among the eye care professionals also being increased. So referral practice has been improved and a lot of patients are being seeking low vision also getting low vision practices over there. Many INGOs, NGOs, and community field workers also being acknowledged low vision services. And the good part is that awareness of people with low vision, like the visually impaired people, also have been aware about the social media through NGOs and eye care professionals that they can get these kind of services and can have their life independently with using of these services. So many of the NGOs have been in collaboration with hospitals. They are improving their setups at tertiary levels and they're equally focused on community-based rehabilitation too, so that the individual who are in rural areas who can't afford these services, they also can have a rehabilitation at their own space. Training of low vision have been improved and many of the ophthalmologists and optometrists have been getting it, that how we can render the services to the needy individuals. Coming to the devices, there are a lot of new devices which has come up, like mouse camera, which is a device which is a simple mouse with zoom camera. It comes in wireless and non-wireless option also. It can simply reflect it on the screen in any of the LCD and LED. It could be reflected and it has both the features or reverse polarity. So you can have a text on black on white background and white on black background. Similarly, side scope CVTV glasses also have been launched for distance and intermediate zone also, which is being very well accepted by the young adults and older adults, especially the watching television and doing their task on the desktop or laptops. Acutech has launched side scope glasses also, which comes in and it has a good binocular field. It could be in a spectacle mounted or in a form of clip-on, which can easily be worn on the customized glasses also. And it is very helpful for focusing for the distance part. There are many portable video magnifiers also being there, which has a different range and the size. This is a 3.5, start from 3.5-inch display to goes to 10-inch and 12-inch display. It comes with a portability also. It comes with a handle also. It's very easy to use also. It has several features. Different contrast can be changed. The text can be zoom in or zoom out. You can freeze the text also. You can convert the text to other desktop also with the help of a SD card. This is a very well accepted device with all age group, even for the children to young adults and the older adults also. And most of the devices have been coming with HDMI connectivity too. So you can have the same text which can be reflected on the any of the LCD and LED with the same features on. Zoomax has launched its 12 high definition magnifier, which has come in a big screen. It could be mounted on a stand also. It has up to 19x magnification and it has an OCR technique too, which basically convert text to speech. So those individuals who are having difficulty in reading the text, they can have a speech option or OCR technique also. This device can be used without stand also. Desktop magnifier is another device which is again very well accepted and it has a camera inside it. So you can have a camera interface the reading material or can have a camera for distance also which can be reflected on the screen. Sometimes the desktop magnifier has a platform also. So any of the reading materials can be placed over here and can be projected on the screen. Filters are being available to reduce the glare and improves the contrast. It comes in a very different range. It comes with a fit over part also, which can be worn easily over the glasses. There's a wrap-on filters also. There's a clip-on filters also, which can simply be clipped on the customized glasses for children as well as for adults to reduce the glare and improves the contrast. Iris Vision is a new device which has a combination of Samsung's VR headset and a smartphone. It is very useful for the distance as well as for near. The only limitation, the device is little bulky in appearance, so not very easy to carry it on. eSight has launched its glasses. Now the eSight 4 also has been launched. It has captures a high quality video. It displays on 2 high resolution OLED screen directly in front of each eye, and it provides the brain with increased visual information to naturally compensate for gaps in the user's field of view. Orcam is a new device which Orcam 4 has been launched, which is an electronic device. A light attachable camera is mounted on the side of a frame, and it starts reading text by simply looking in the direction of some text or by using the finger pointing option, and it starts reading on. This is also a very good device for futures, for especially severely visually challenged person who can see the device. Many of the computers technologies also software is also available. JAWS is the oldest one, is Job Access Based Speech is the oldest software which has been used. It has 2 versions, basic and advanced, and it has OCR technology too. So it can be a optical character recognition. It can speech out what is being written over the text. NVD is another software which is non-visual desktop access. It is used by many of the students, and it's very good for study purpose and most commonly used by students. There are other screen magnifier which comes in Zoom, Text, or Magic, which can be installed. Hello. So it can be used, and the magnification is from 2x to 16x. With their own setups of system, it can be highlighted. There are many apps which is being used by the mobile softwares, like Kibo app for using that students for ebooks. Money is a mobile aided note identifier is a new app which is being launched by Reserve Bank of India for currency identification. It can be simply loaded from the Play Store for any of the Android phone and can be used to identify the currency. Another app, Lazarola, for the navigation also. It also can be used by simply downloading from Play Store and can be used by the visually challenged person. Many of the Android phones also have a default by Google TalkBack, and iPhones have a voiceover. The simple phone can be converted to a TalkBack and voiceover for the different commands. There are many talking devices also being available which converts text to reading text to and it's a real speak, and it comes in different versions also. So for the severely visually challenged person, if they have, especially the older ones, if they have a difficulty in measuring their blood pressure or temperature or glucose monitoring, all talking devices being available, which can easily be used by these individuals, whether it's a talking calculator, watches, wall clock, etc. So as far as we are moving to a new world of low vision, I'm sure in coming time we'll be having more accessible and more acceptable devices in future with the affordability to all. And of course the challenges is big, but our commitment is continuous. Thank you. Thanks a lot for everyone for making me these presentations. And I'm sure making low vision care to all the needy ones would make an enormous difference in the quality of life. So, thank you.
Thank you, Miss Sonia, for your nice presentation. And, you know, as an optometrist who I have some experience in low vision clinic, it's very challenging. It's not about just checking the patient's eye. You have to be psychologist. You have to have sympathy. Patients come to you with absolutely no hope. It is very, very challenging field, I must say. Okay, if you have any question, please just write it down in the chat box and we will just discuss it with the speakers after every 3 talks. And let us introduce the second speaker, Dr. Kathy Stern, which is she is a behavioral, developmental, and neurooptometrist near Boston in USA. Her practice is devoted solely to vision therapy, myopia control, and vision rehabilitation. She's a current trustee of the College of Syntonic Optometry, and also she teaches about the use of assistive technology and sport vision. She's going to talk about advances in vision therapy, optometric phototherapy. Dr. Katie, are you here? Yes, hello.
Okay, now it's there. Can you hear me?
Yes.
Yeah. I'm unmuted. Can you hear me?
Yes, Dr. Katie, very, very clear.
Oh, good. Okay. I didn't. So let me start. Welcome, everyone. Good morning, good afternoon, good evening, wherever you are in the world. I wanted to talk a little bit about optometric phototherapy, sometimes known as Syntonic phototherapy. And so what I wanted to do was start off by talking about dealing with light and the fact that everyone needs to mute, please.
Dr. Katie, just a second. I think Sonia ma'am microphone is on. Yeah, it's okay. Sorry.
Yeah, got it?
Yeah.
Okay, thanks. So when we talk about healing with light, there are a lot of physiological effects of light. And so when we talk about vision, we're talking about visible light. When we talk about the non-visual optic pathway, we're talking about the intrinsically photosensitive retinal ganglion cells. And there's something called photobiomodulation. It used to be called low-level laser or low-level light therapy, which uses visible light and near-infrared light. This is actually a picture from a mouse visual system, but very similar to ours. And I thought it was a good picture because it shows that light coming into the eye really goes to many different places and has an effect then on not only vision, but our circadian rhythm and therefore sleep. It has an effect on the pupillary light response and the direction of attention. In optometric phototherapy, it really started probably even long before the 1920s, but in the 1920s, Harry Riley Spittler was an optometrist who wrote a book about syntonics, and he discovered that specific light colors delivered through the eyes could have a very powerful effect on our physiology. And he really looked at it as if there were imbalances in the autonomic nervous system. He called it syntonics, and it was frequencies of light applied through the eyes to rebalance the body. And then there was a practitioner named Charles Butts, and he wanted to make it more accessible to the general practitioner. So he, through the College of Syntonic Optometry, moved a little bit away from just looking at the autonomic nervous system and tried to combine it with typical optometric testing, such as forias and accommodative reserve, pupil responses, and visual fields. And then in the 1980s, Larry Wallace, who still teaches in the basic course, he developed what he called a syndrome approach, and that's what I'm going to go through with you today. And in 1990, Jacob Lieberman, who has been president of the College of Syntonic Optometry, published a book called Light, Medicine of the Future. And he was so far ahead of his time, the book still sells very, very well, all these many years later, but it is about vision and light therapy. And so when we talk about it specifically for optometry, conditions that we think about are strabismus, amblyopia, binocular vision problems, learning-related vision problems, and traumatic brain injury. In terms of practical syntonic phototherapy or optometric phototherapy, We think about diagnosing what are called the syntonic syndromes, and I'll be going through those. We take a very, very careful history. As I like to say, history, history, history. And we look at pupil testing, and we look at a kinetic or campometric visual field. And we will talk about the filters and filter combinations coming up. So when we look at the autonomic nervous system, we know that the parasympathetic branch of the autonomic nervous system controls the near triad of convergence and accommodation and pupil constriction, while the sympathetic branch controls pupil dilation, divergence, and relaxing of accommodation. The autonomic nervous system is also involved in blink rate, tearing, and intraocular pressure. So what are some of the things we look at in terms of the effect on the autonomic nervous system, especially when we're looking for autonomic imbalance? And three of the things that we really spend a lot of time looking at when diagnosing a patient is something we call the alpha omega pupil. Normally, when you shine a light into the pupil of someone's eye, their eye will remain constricted for a minimum period of time. There are some differences in the literature as to how long that might be, but we look at it for at least 10 seconds. If when I shine that light and the pupil constricts, it almost immediately redilates. That's called the alpha omega pupil. It can't sustain that constriction under light. We also look at oculomotor imbalance. If you have very poor pursuits or saccades, often one of the contributing factors is that your functional visual field is narrowed, and therefore you're losing track of what's moving in that space in front of you. And the other thing we find is often when the field is constricted, there's reduced color discrimination. A person may not show a particular pattern of a color vision deficiency, but they do have difficulty with some of the plates on the Ishihara test. So what is a functional visual field? Well, it's a field that is reduced in size, and it's in the absence of any organic cause. So this would be a more normal visual field. The black line actually represents what is a white target. And the first thing we look at is when you can see it moving, and then when it stops moving, you see it as a white form. So it's usually a small round circle. And you see it here in black because it's obviously easier than to see on the screen. And then we map the color fields, and they are different sizes. The green is usually the smallest, and then red, and then blue. So what we look at is motion, which is where, as I'm bringing something in from the periphery, you first notice that it's moving, but you're not sure of its shape. And if I stop moving it, you may even lose track that it was even there. And then the form field is when you can notice its shape. So if I'm bringing a small round target in toward the center, and at first you notice it moving, soon after that, you will be able to tell me that it's a small round shape or it's a white circle, and I can hold it still and you will still notice it. That's called the form field. And then we do the color fields. We generally test green and then red and then blue, so that as you're making marks on the chart, if you're doing this manually, there's also a way to do it with a computer program. But either way, if there are marks already on the chart, it tends to be a little bit distracting. So if we start with the smaller field, then the newer marks will be further out. And what we say is that there should be no overlapping or what we call interlacing of the different colors and the white. We also map out the blind spot. And in many cases, there's an enlarged blind spot. For a long time, there was some talk that it was a swelling of the nerve, But I think that today, with more of the technology we have to look at that, it's not clear that that's what's going on. And so some people looked at it and they feel that there's some type of anomalous projection, so that you are noticing that target when it goes from non-seeing to seeing, it's taking you longer to find it or to know that it's there. And your sense of sort of the spatial aspect of it is off. And so what would a field look like if it were constricted? Well, here's one where it's constricted to 5 degrees in all meridians. And I will tell you, I have seen fields like this. Also, if you have some kind of toxicity or brain injury, we sometimes get some unusual shapes. And when we look at the blind spot, if this is a normal blind spot, roughly the size of where it is on the chart there, you can see where it's just a little bit larger. Here's one that's quite a bit larger on the bottom left, and then you can even have some irregularities. If it's just down a little bit from where that spot is on the chart, that's not a problem, because it may be that yours is just in a slightly different place, or maybe your head is a little bit off in the instrument. Now, when we talk about the therapy, we use Greek letters. And I will show you in a moment that I also put them in English so they're more easy to understand. But basically what you need to know is this. There's a blue end with deeper blue colors at the long end and more green in the middle or toward the middle. On the red end, you have sort of you have a deeper red at the end, and you have a more green yellow, or some people call it a lemon color, toward the middle. And right at the very middle, you have a kind of combination of the red and blue, and you'll see what that's used for as we go along. So again, here's just another way of looking at it with a couple of additions, but basically the red end is much more stimulating and more sympathetic stimulating. So for example, if you had someone who was an esophore or esotropic, you might be wanting to use colors more in the red end because it stimulates more of an exo response. It also tends to be used for more chronic conditions, where the blue end, it stimulates the parasympathetic system. It stimulates more of an ESO response. So you would be using it for convergence insufficiency, for exotropia, and with more acute conditions. So here's a few of the syndromes that I mentioned. So one of them we call the mu delta or chronic syndrome. And we refer to it in terms of that lemon color, that's the red end, but more toward the center. And it's more of a physiologic stabilizer. And the kinds of things that you might see when you would be thinking about utilizing these colors would be convergence excess, esophoria. We say the alpha omega pupil, but you'll see that that's true in a lot of the syndromes. And also poor oculomotor control is seen in more than one syndrome. You will get or notice a constricted field. And when you're doing your typical optometric testing, you may find low recovery on ductions, especially base in. And if you're talking with the person, you may find that they have some type of neuroendocrine imbalance, or there's a toxic situation, or maybe they have some kind of tooth infection, and they may have some chronic health problems. And what you're looking to do is to stimulate that sympathetic system and create that more exo response. And then we have what is sometimes called the lazy eye syndrome. And it's called the alpha delta syndrome. And the color we use to represent it is more red-orange, a deeper red, where you have both sensory and motor stimulant in the color. And it's used for amblyopia, more for esotropia. Again, you'll see constricted field, but you'll also see very constricted vergence ranges. There would be reduced acuity in one eye because it is about amblyopia. You may see a head tilt or turn. Depth judgment, stereopsis will be affected. Some patients may report diplopia. And we do find that many of these patients report a slow reading speed and often poor handwriting. It's to stimulate the sympathetic system again, but it's used especially in long-standing strabismus. And then we talked about kind of a a red-blue combination. That's that middle of the balance board. And it's what we call the emotional fatigue syndrome. We represent it more by this ruby color, which is again, kind of that red and blue combination. And you will see the alpha omega pupil. You may see an exophoria or exotropia that's more fatigue related in that it fatigues. And low breaks and recoveries, especially for base out. And you may find that the person also has adrenal fatigue. They may report photosensitivity, transient blurred vision, overall general fatigue themselves, and headache. And what you're looking to do is to balance the parasympathetic and the sympathetic. When we look at what's called the acute syndrome, it's called mu upsilon. I'm missing the end on the upsilon there. It's turquoise or blue-green. And we think of it in terms of recent head trauma. Maybe there's been an anoxic event or stroke. Often the patient will demonstrate what many of us have come to know as post-trauma vision syndrome, where you have exophoria or exotropia, maybe convergence insufficiency. You will often see this alpha omega pupil. The blind spot will frequently be enlarged, and the person will definitely show poor oculomotor control and likely poor accommodation. They may have a headache. They may complain of motion sickness or vertigo, maybe transient blurred vision. I have patients who often will say they can see it, but it's not clear. And there may be diplopia and even monocular diplopia. And what you're looking to do is to stimulate the parasympathetic system. Now, when we do these colors, we don't always do them alone. We often do them in combination, because if you're using a strong color toward the end of that balance board, so the deeper red or the deeper blue, you don't want to stop with that color. You want to then use a color that's more toward the center. We always say you want to end near the middle of the balance board. And so mu upsilon, which is near the center already, can be used alone. There's another color we didn't cover, which is very close to mu upsilon, called omega, and that can be used alone. But if we're using upsilon omega, which is a deeper blue, we would then end with mu upsilon. And there's a slightly more intense deep blue called upsilon omega D, and that also would be with mu upsilon. So here's a picture of some of the colors. So we were talking about things like mu upsilon, upsilon omega. You can see they're the deeper blue. You have alpha delta, and then you would have mu delta. So you can appreciate just by looking at them some of the depth of some of that color. And so the treatment is that you're shining this light into the eyes. Generally, the person sits and looks at the light for 20 minutes. If we're using two combinations of color because we've used a deeper color and now we have to end with one that's closer to the center, it's usually 10 minutes of each one. And then we want it done about 4 times a week. So we used to try to get patients to come into the office. Now we find that's more of a challenge. So there have been a number of home instruments developed where we send the therapy home. We still try to do at least 1 session maybe per week in the office if we can. And many of my patients who do this are also starting to do active vision therapy. So they're coming in at least once a week. If not, I'll let them do it just at home, and we try to monitor them about every 8 sessions. So if they're doing it 4 or 5 days a week, and I will have them do it for 2 weeks, and then when they come in, I repeat their history, I repeat the visual field that we do to see and what we do know is that generally it has low risk and very few side effects. So what do we see after treatment? There's a restoration of the visual field. You will then notice that there's an improvement in oculomotor skill and binocular status. The patient will often report decreased headaches or asthenopia, and they will often tell you that they have increased attention and concentration and memory. And I believe that that's because when that visual field functionally is constricted, you're only taking in a small amount of information in any one look. And everything is like in pieces. It's like a jigsaw puzzle that there are all these pieces, but you don't really know how they come together. And when that field opens up, you get a much better picture of what's going on in the world, and you can hang on to more information. So what are some things you want to remember? We know that light is a primary tool to rebalance the autonomic nervous and the endocrine system. You look for this enlarged blind spot or a general constriction of the field. We do find that in brain injury, we often go to the very deep blue, the upsilon omega D, for pain. And it is low risk with a high rate of success. Now, I know that this has been a very quick walk through, maybe even a run through optometric phototherapy, and there are certainly many things we didn't cover, but I hope that it was an opportunity for you to at least become a little bit familiar with what it's all about and the fact that we do concentrate a lot on these 4 syndromes. And it is a very powerful tool. I found when I learned to do it that it really made a difference for some patients where I was getting stuck in typical vision therapy that I was doing with them, that by doing this, we were able to get much further along and they were able to gain much higher level of skill. So the minions and I thank you. And there is my name and my email, and I'm certainly open to some questions, but I think that you can look at the College of Syntonic Optometry. It's csovision.org, and we do have a special dues fee or membership fee for those coming from countries where optometry is certainly not at the same level where it is here in the US. And so you're able to join for a very nominal fee, and you can then take advantage of a lot of what's on the website. And obviously with the pandemic, we've been giving a lot of our courses online, so people have been coming from all over the world.
Thank you so much, Dr. Kathy, for your
So
presentation.
I don't know if there are any questions. I'm going to open the chat here.
Yes, if anybody has any question, please write it in chat box. And I request everybody except the speaker, please just turn off your microphone.
I don't see any questions. I'm sure there may be more later, so we're good for now.
Yes, so I just, we told them after, we just finished with the
third. Oh, you did say right after every few speakers you were going to do it, yeah. Right? And I will put my email in the chat.
Yes, they asked for your email. All right, everyone. Let me introduce the next speaker, who is Mr. Prem Kumar Singh. Mr. Prem is a senior faculty in pediatric optometry, orthoptic, and binocular vision, and head of Department Optometry Science and at Dr. Shroff Charity Eye Hospital. He was honored with Best Optometrist of the Year award in 2014 for clinical and academic contribution and Best Oral Paper award at 14 Vision 2020 conference in June 2018. He has 20 years experience in teaching ophthalmologists, optometry fellows, and interns. He is the Vice President of Delhi Optometry Association and Education Committee representative of Indian Optometric Association. We have Dr. Prem here today with us to talk about optical dispensing, a backbone of eye care. Welcome, Mr. Prem.
Thank you, Samaya. Am I audible?
Yes.
Thank you. I know some of you must be thinking, who know me, that why I have taken dispensing as my topic today. That's not my main area of working. Just to share, we're not knowing about this. From last 6 years, I've been looking for the business of business at Dr. Shroff Charity Eye Hospital, and the main objective was to have a conversion improve, where the uptake for the glasses for our patients become better, so that all the hard work which is done in giving the outcome of quality refraction, and so that patient actually goes for a quality dispensing along with that. Well, before I go for my main talk today, I'd like to just refresh with some of the important areas in terms of blindness, and which can correlate with where the optometrist fits in better in terms of the dispensing. So we all know, in fact, the International Agency for Preventive and Blindness, if you can go to their site, they have very clearly highlighted about the cataract and the refractive error being the most like prominent causes of the blindness worldwide. As you can see from the bar itself, where this is where the refractive error stands, and then followed by the cataract, and then the other areas like macular degeneration, glaucoma, diabetic retinopathy, and other causes. From optometry point of view, if we see, it's not only this area where we need to actually ensure the quality refraction, even in this category as well as in these categories. In fact, I will say it's more important to have a quality refraction for this category, because even a difference or improvement of one line can make a huge difference to their life, to these individuals. So overall, if we see in eye care, nothing moves without the refraction. So all the hard work which is done to achieve that good outcome of visual acuity for the patients in different category, and then we finally prescribe the glasses, which averages to around 25 to 30%, maybe somewhere it's a little more, depending upon the kind of setup it is. But broadly, if you see, this is where it ranges between 25 to 30%. If you see the further data from the world, it's almost 160 million of the people who actually are impaired for that because of the distance vision issues. And then majority, that is 910 out of overall blindness, which is because of the refractive error, that is 671 million. 510 are basically affected because of the near vision issues. And countries like ours, India, we all know what the status is. Almost 270 million people actually are affected in India itself. And where we all know that cataract and refractive error are the major reasons behind it. It's not only the refractive error we're talking about, which is not corrected. There is a major chunk other than the refractive error which is not corrected, which is the under-corrected refractive errors, or not having the rightly corrected prescriptions that they are wearing. Many times they wear either under-correction or over-correction, or maybe the person who has dispensed them the glasses, he has not understood the visual need of an individual, so a right design has not been prescribed to the individual. Or there could be many reasons. I know for many of my optometry friends, they love scrolling their mobile by enlarging their font. In fact, even the all phone numbers, what they have captured, they have a larger font, and it's easy for them. They can manage that way. It's advantage, definitely. But there is a stigma in the people who don't want to wear the glasses. And somewhere, because of this stigma, or not going for a right correction, or just going for a reader, not having a distance correction, or not going for a complete correction, somewhere it limits the potential of the individuals. It gives them somewhere or the other the reasons for not liking the glasses, not being comfortable for the glasses, and somehow always coming back to the clinic or not able to perform to the best of their potential. I actually quote this saying very frequently, where one has to feel the best to work for the best, and one has to see to the best if you really want to feel the best. So this is where actually, if you see even at the site of IAPV, they have clearly mentioned about the millions of productivity loss because of the blindness, one area, and then they request the countries to invest in the eye health, which can improve the well-being of the people, education of the people, increases the workforce and the community participation. And good vision is the fundamental to achieve the sustainable development. So all these areas, if you see, we're talking about, the agencies are talking about, the NGOs are talking about, the eye care practitioners are talking about how important the good vision is. We know about the product availability of products actually. There are single vision lenses available, spectacles, bifocals, PAL, readers. If you see, we all have moved from this tube kind of TV to HD kind of design. And in fact, we all love having it in our house. We want to have different kind of dresses. If you see, formals, informals, and we're really happy and we always want to have that kind of collection. But when the things come for the glasses, we actually move in a very different direction. Whether you're talking about the planners of the country who are looking for this, who are to plan for this, the eye care in the country, or even the practitioners, we want to give a best for the refraction, and the service ends there. This was that actually I've taken again from the IAPV site only. And if you just see the national indicators, and it's alarming actually for any optometrist or eye care practitioner, it should be a thought for the for today actually. If you see, the country has ophthalmologists. We have optometrists almost 54,000, which is 39.1 per million. We have another category, we call them allied ophthalmic personals. Actually, not very clear about what all it includes, but that's around 40,000. But where is the category of dispensing opticians or dispensing optometrists, I should say? There's no planning as such. You've done your best, but where is the dispensing part? Forget about that. Let's go ahead with this. Recently, on 16th of March, the Indian government, the Rajya Sabha, has passed a bill to standardize the paramedical care in the country to have a good education. And optometry is the part of that. There are 11 categories in which optometry is also included. And if you see, these are the professionals which are going to be covered in this health bill. So you're going to have a council in the name of ophthalmic science professionals, which will have optometrist, ophthalmic assistant, vision technician. But where is the dispensing optician? Is he not important in the eye care? Well, that was the reason actually I thought, let me have some important data. But does it not open more opportunities for the optometrists, 54,000 optometrists, to actually look towards this area more seriously? And if the government is not thinking about that, maybe we as the eye care practitioners can play a key role into this area. Most of the time, if you see, when people talk about dispensing on these big platforms, we're talking about the readers, the adjustable glasses. We're not talking about the other available options which can increase the potential of an individual, who can make an individual much more comfortable in his routine by understanding the visual needs of it. Just think of somebody who is requiring a glass, basically a -2 diopter at the age of 50 for the distance, and you just give him a distance glass. You haven't gone for a bifocal or a progressive lens. So for near, he'll always have to take off his glasses. He can't read the things clearly for near. When we have the options where he can go for a single pair of glass, which can make him much more comfortable for his routine by looking at the distance as well as for near. I know initially there were some issues with the design of the lenses. If you see today, the technology has refined these progressive lenses to much better extent. You hardly see the aberrations in the side. You can have a uniformly clear vision at all variable distances. So coming back to the optometrist part, actually, what we think is the quality service to our patients ends when the quality of refraction is done. Or doing quality of refraction completes the service for our patient from an optometry point of view. Does that mean that So you do your examination, you complete his examination, and when patient needs the glasses, you hand over the glass prescription to him. In fact, your prescription doesn't have even the specifications, your recommendations, a single vision, a bifocal, a progressive, and the particular coatings, whatever is required. And you give that patient prescription and you leave the patient for the opticians, where there's no regulated, no certified, no formally planned the program in the country to have a trained, skilled manpower to actually dispense over your prescription. So what I recommend here is actually to have a complete office of yours, wherever you are practicing, what kind of setup you are practicing, a big hospital, an institute, a small practice, or your own practice. So to have a practice along with the optical dispensing, that brings actually a confidence in the patient, makes it much more convenient for a patient to avail the service from a same platform. Or we all know about the marketing that the companies does in terms of service, but there's no service. It's more about the selling a product, because the patient in whom you as a clinician has given half an hour or more than that to understand the visual needs and understand the label of his visual acuity, I'm sure you are the one who can decide, you can recommend something much better than what somebody who's standing as a sales guy who can actually advise to your patients. So our objective should be to capture these kind of patients, which will definitely improve the satisfaction of our patients. Along with that, it brings the business to you, with which you can definitely have your much more better developments in your clinic. So it's not only your patients, you should always aim for to capture majority of your patients, and anything if you get from outside, that becomes a gravy over it. So what I'll say here is, there was some information from my own experience at my hospital, where our actually optical service, we had our own optical service, we were struggling with it. In terms of not having the capturings properly, it was hardly 18% of patients who were opting for the dispensing from our center, from our hospital. The rest, all they were taking their prescriptions and they were going out. So we tried to assess where the things are not going appropriately. So we tried to, first, we tried to understand what are the patient's expectations, what is our label of patient who come to our hospital, and whether the inventory that we have at the store, does that match with the expectation of the patients. Being a tertiary hospital, a lot of patients actually come from out of city. They are not from Delhi, they come from other places. So they may not be liking to order a glass or getting it couriered. Rather, they will prefer to get it locally from there. They can go back for any kind of service. So then we started a 30-minute service for patient that we introduced, where within 30 minutes, they can get the glasses made for them. And another important area was where we started monitoring the conversion data of each and every optometrist. I'll just share the data here from only one of my clinic, where 5 optometrists work in that particular area. And if you see the variable outcomes of conversion, somebody who is having a conversion of almost 75%. Another one is around 60, and then you see here somebody at around 25% of conversion. So same infrastructure, same level of patients coming to the same clinic. Why there was variations of the conversion? Why the uptake for the glasses for the person who was prescribing the glasses was much more than the other people? And that's why we try to assess what was the different that the person was doing. In fact, we tried 3 different models. If you see here, people say, let there be an online prescription getting released at the optical counter and guide your patient to collect the prescription from the optical counter. That helped us actually in capturing 100% of patient. But the conversion was around 26% from that 100% reporting that we have at the optical counter. There was another model we tried, releasing prescription to the patient, which usually happens at most of the places, through which only 25% of patients were reaching to the counter, and we had a conversion of 17%. The third model what we tried was, let the optometrist, after finishing up the workup for the patient, walk to the optical store wherever it is required, whenever it's possible. And there, of course, it was not a 100% reporting, it was around 86%, but the acceptance for the glasses, uptake for the glasses improved to around 55%. So this is how from 18% we could move to 42% averagely conversion during that period for our patients. So now key points I'd like to highlight here is, being an optometrist, of course, we does the best as a clinical person. We does the best refraction, try to give the best visual acuity for our patients, and we sign as such as the best prescription for our patients. But when it comes to the retail things about the products, the design, what I should be recommending for the patient, somehow we are leaving that to other people. So after we have done the complete details examination for our patients, history review, we need to dig out. In fact, we need to work more as a detective for the patient to understand the exact visual needs of the patient. And once you have understood that, then your prescription should capture whether somebody needs a single vision of glasses, separate pair of glasses, bifocal, progressive lenses, requiring any additional coatings or any kind of transition support. So once your prescription has that, then definitely that becomes a different as a recommendation for the patient as a doctor's advice, not as a sales recommendation. So key point, if you say in the sale is not actually what the sales guy is telling, what the product you are recommending in your examination room, where you might many times have some questions from your patient, and which encourages actually, which gives an opportunity to you to better explain about the product and its benefit. And by the time you finishes that work, then patient is more probably you'll find he's actually taking your advice and recommendation as a doctor's recommendation, not as a sales pitch or a sales recommendation. And if you really are fortunate to have a little time in between, just hardly takes a couple of minutes to walk with the patient to the optical counter, and where you can let your sales guy know what you have recommended to the patient. And during this time when you're walking, you will have an opportunity to talk about that particular product and the design at least a couple of more times. So before he reaches by the time to the optical sales, the person has heard about that product and the design at least 3 to 4 times. And the same thing you are telling the sales, what is that you have recommended to the patient and what patient actually is looking for. And then you can walk up from there, let the patient be working on that. So this is how you can just simply see, I know this patient, I've taken his picture here. He was using almost half of the power actually what he really required. And the reason simply being, he said, it may be much thicker than what I'm using. So we advised him to go for a full correction high index with ARC, but although he didn't go for a high index, he has gone for a normal lens from outside, but he has chosen a metal frame. Then we asked him to go for another pair of frame from the hospital shop itself, where you could have a sheet frame which can cover the edges of the patient. And you can see how the eyes look into this. Just by adding on anti-reflecting coating to the lens, patient actually acceptance for the glasses and the higher number was much more on the better side. So taking those extra couple of minutes outside of your examination room is truly worth it, as I'll say, for your practice to grow as well as strengthening your relationship with the patients. So this is what I'll say, regardless of your practice settings, whatever kind of it may be, an institute, could be a hospital or your small setup, if you can really have this philosophy of dispensing through optometrists and ophthalmologists, where you are recommending the patient as an advice of the product for the design of lenses, that can always help you in improving the patient satisfaction and growing your practice further. So just to summarize the key points, patient case history as we does, the eye examination play as a detective to uncover all the visual needs. On the basis of that, make your recommendation in the prescription, pass the authority to the sales guy for the dispensing, and then definitely that helps you in building up that relationship. So vision plan that includes quality refraction, good eye wear, and selection of quality frame style can always help you in providing more satisfaction outcome. And of course, you can always have a good doctor and patient relationship with the good satisfaction of your patient at the end of the service. Thank you so much.
Thank you, Mr. Prem. You're very right. And I think, what patients gonna wear is the fruit or result of what all ophthalmologists and optometrists has done. And I think as an optometrist, as long as you are in your examination room, is like a temple for the patient. They trust you because they know that you don't care about how much money you're gonna spend, or you're not benefited from that. So it's better you just mention what it requires definitely for him. And when it comes to optical salesman, they just talk about different products and why this product is good, this is bad, but which one is good for you? So you are definitely right. This is the optometrist's job to just tell the patient what is good for their eye. Thank you so much, Mr. Prem. We will get back to you at the end of the session. Okay, now I would like to welcome Miss Yogita Rajganti from Delhi Optometrist Association for giving a partner talk. Yogita is the editor, Corporate Affairs Committee and Legislative Committees member in Delhi Optometrist Association. Yogita, ma'am, are you there?
Yeah.
Hello, welcome.
Hello, yeah.
Is
Good
the slide
morning and good
visible?
evening, everybody.
So
No,
can we
friend, sir.
No slide? Okay, wait, I'll do it again. Is it now? No.
Mr. Prem, are you going to share something with us?
Yeah. I was trying to share the DOS slide actually. Yeah.
All right, okay.
Okay.
So, Ms. Yogita, we will get back to you in few minutes. Thank you. Yes, Mr. Prem, you can carry on.
Can you see the slide? Is the slide visible now?
No, sir.
No, sir, it's not visible.
Okay, can we ask the next speaker to go on? Meanwhile, I'll work on this slide. So we can have the DO talk after. Yogita, sorry, I know it's not working. Or if you want to try from your side, Yogita, you can do that.
Anyway, we're gonna have you at the end of the session, so you can just carry on that time. Is that all right?
Okay.
Okay. So, Miss Yogita, are you there?
It shows that the screen sharing of my is paused actually. It's paused, it's showing. Not happy. It's in my screen sharing is paused. Maybe I'm not able to do that. Can you share? Could we see that? No?
Yes,
Yes,
now
sir.
it is visible.
Yes,
Okay.
yes.
We can ask Yogita to resume.
Yeah, okay. Thank you so much for all this exercise. I'm sorry to bother you. Good morning and good evening, everybody. And thank you, Vision Science Academy and the Dr. Shroff Charity Eye Hospital for giving me this opportunity to present on behalf of Delhi Optometry Association. Can we have a next two slides, please? Basically, a Delhi Optometry Association founded in 1996, way back, and many seniors members worked and founded this association, which was a need of the hour that time. And the current president is Mr. Anil Tyagi, who will be answering your question if you have after this session. Yeah. So this association represents optometrist discipline, of course, professional in that particular Delhi and NCR area, and which works in a favor advisor for the Optometric Council instead of the Ophthalmic Science Council, which was the latest bill which Mr. Prem also talked about it. And as I said, it founded in 1996, which has generally grown up from 16, 18 members to now today we have more than 230 members. So what is the vision of this association is of a world where the optometry makes very high quality eye health and the vision care accessible to all the people across the country. And the mission can be to establish optometry as an independent profession across the country, which can facilitate the Department of Optometry development and within the Delhi NCR, which supports the optometry promoting eye health and vision across the state of Delhi, and which was the founder member of the Optometry Federation. It is also the member of the National Association, which is Indian Optometric Association. Of course, Delhi Optometry Association has been represented, World Council of Optometry and Asia Pacific Council of Optometry, and many other international platforms in a different manner. There are a few achievements which I just want to highlight. They have changed the nomenclature or the degree program in the Bachelor in Optometry at the central government hospital and central level. And the central government itself hired the degree program optometrist. They have changed the nomenclature of the refractionist to the optometrist at the central government scheme level. There are different kind of memberships are available with the Delhi Optometry Association, which start from the life member, annual member, student member, and corporate member. So there are regular members, and the different fees and structures are there on the website. Any interested candidate from across the country can visit the Delhi Optometry Association website, that is www.doaindia.com. There are few activities have been conducted during past 2 decades. And of course, on the contribution to the eye health and the vision community program and projects and development and educational and seminars, those have been organized by the various modes and the various platforms along with the different associations. And Delhi Optometry Association now going digitally also. And we have definitely as an association few future plans to take care of the nomenclature, to take care of the unification of the standardization syllabus. Across the country, you can have the one nomenclature, one degree program across the country, and many other government level, state level, to highlight about how the optometry profession grows and how they can contribute to the government schemes, government programs, visual impairment, and different ways. The Delhi Optometry Association board members are very active, and they've been participating in various activities. Few board members who are pioneers and who are the pillars of the Delhi Optometry Associations, who founded this, and like-minded people came together. And today, I think so, Delhi Optometry Association is very proud to have all the seniors members across in their team members. So starting from the chairman to president, vice president, secretary, joint secretary, and all executive committee members and regional and legislative committee as well. So we are very fortunate to have all the members with their support and contribution. Delhi Optometry Association is growing way far. This is the contact details of the association. You may visit for website of doaindia.com, or you can write your any questions, any queries on your email address, which is there on your screen, or maybe at the end of the session, you can connect with our president, Mr. Anil Tyagi, who can be answerable to any of your questions. I would like to thank once again both the organization for giving a few minutes to give us an opportunity to reach to our participants. And I would like to wish that today is been declared by United Nations World Down Syndrome Day. I hope the eye care professionals come together and make a lot of difference to their life, and we all can make a difference in rehabilitating and make them independent. And I would like to wish all the participants in advance, wishing them a World Optometry Day. Thank you so much, Mr. Prem and Dr. Kathy, for giving it an opportunity. Thank you.
If I can request Mr. Tyagi, the president of DOA, if he's there, if you want to share something, sir. At least few words, sir.
Thank you, Yogita. You have elaborated all the details about the DOA, and there is no need to elaborate more right now. I am especially thanks to organizer of this CME, Vision Science Academy. Such type CME should be continue with the collaboration with this Delhi Optometric Association in futures. I am especially thanks to Mr. Mandal and Dr. Kathy and Somaya. They're well organized, and there is such type of the event should be continue in the interest of the optometry. I think there is no need to give more suggestions regarding the betterment of the optometry, but DOE will always with the support of the optometry profession and professionals. Thank you very much. If you have any query and any questions regarding the status of the optometry and latest council is going to be established by the central government parliament law, so we can debate, we can give the answer. Thank you very much.
Thank you, Anil sir. So if anybody has any question, please write it down in the chat box. Now is the time to answer the question if you have any. All right, so let me just introduce the next speaker, Mr. Obi Malo. He's a very interesting guy. He's a young, dynamic leader within the healthcare industry who championed and pioneered various innovative products and solutions. He's the CEO of few websites. He's gonna tell you more about it. He's an award-winning optometrist, training and development consultant, global speaker, multi-published author, strategic innovator. As he believes he's a nice guy to be around, which today he's going to talk about the unlocking the growth potential of your optometric practice. Obi, are you here with us?
Good day, how are you?
How do you feel that now you jump to the other side of the table? Because I've seen your website, you are the one always interviewing the great people, great ophthalmologists, but now you're the best.
No, I'm excited to be part of this amazing platform today. Thank you very much to Vision Science Academy for inviting me to participate as a speaker at this prestigious event. It is an absolute privilege and an honor, and I'm fully convinced that today, as you talk about unlocking the growth potential of your optometric practice, the presentation will add great value to each and every single person, whether you are a dispenser, an ophthalmologist, or an optometrist, whatever role you play in eye care. I'm fully convinced that this presentation will add value to you. To be amongst these amazing speakers that have been speaking so far, it is truly amazing. And so I hope I'll be able to measure up to the level of standard that has already been set by the previous speakers. And so, yeah, let's get right into it. I'm a very informal individual, and so I want to make this as fun and as practical as possible. And so, yeah, let's get right into it. Can you all see my presentation?
Yes, very clear.
All right. All right, so obviously, had it not been for this pandemic, it would have been an absolute pleasure to do this in person. So I just showed you an image of the different types of environments that you will normally find me in when we do workshops, when we do conferences, when we do events. And so I would love for one day post this pandemic to be there in person to do this presentation. But for now, I guess we'll have to settle for this online platform. I've written a couple of books, so as much as you always see me on social media, there's a lot of work behind that, and so these are the books that you can actually order directly from. Sorry, what you were saying?
It was just interruption. I'm sorry, Obi. Yes, you can carry on.
No problem. Okay, I'll continue. So yeah, these are some of the books that we have written for the eye care industry, and they are available at books@visionstraight.co.za, and I'll put up the email address later on. And so yeah, the presentation for today will be in 5 parts. 1, marketing. 2, content development. 3, your target audience. At the end of the day, your patients are very, very important. Without them, we don't have a business. Number 4, how do you develop your unique value proposition? And of course, number 5, how do you operate on a higher level of excellence than you have been before? So that's what we'll be focusing on during this presentation. All right, so I wrote here on the slide that you're looking at that your business offering needs to be entrenched in patient minds and behaviors. And currently, patients are getting access to our businesses either as a direct referral, websites, social media. They were walking by in the area that your practice is located in, or you are using opportunities such as influencer marketing and so forth. Whatever method of communication that you're utilizing, to connect or reach out to your patients, one thing is very, very important, that you have to focus on the experience that patients are going to get when they engage with your practice. So if a person makes an appointment with you and it's the first time that they're going to come to your practice to have their eyes examined, as a practice, you have to be thinking of this person that is coming to our practice for the very first time. What is it that we want them to experience? What is it that we need to do to exceed their expectations? And so it's very, very important that you as an entire practice have an awareness of what the patient requirements are, what the patient expectations are, so that with every single patient that comes into your practice, whether it's a first-time visitor, whether it's a follow-up visitor, or someone that has been at your practice for years, you need to have an awareness of, are we exceeding this person's expectation? Are we delivering way above the expectations and the requirements that they have? So as we go along this presentation, one thing that I want you to immediately put at the back of your mind is the patient experience. I'll give you an example. I attended a university lecture, the university launch 3 years ago. And when I was registering online, the organization team that sent back confirmation of my registration, I received the message directly from the CEO. It felt so personal. It felt like the CEO knows who I am. The CEO of that organization is looking forward to come and see me at this event. So then the question that I have for you as practitioners listening into this is, when a person books, for example, the appointment to get their eyes tested online, you send a confirmation message that the appointment has been booked. Is it a generic message, or have you personalized that message where the message that you have written, it's from the optometrist saying, hi, and you specify the person's name. Hi, Dr. Mandal. We look forward to come and test you, to come and see you for your eye appointment on this particular day. Take care. So it's very, very important that you already start thinking of the patient experience, because by you sending such a direct message that is very personal, it makes the patient feel like, wow, this person is already looking forward to seeing me, as opposed to just saying appointment booked and you just wait for the patient to come. So just think about that as we continue with this presentation. So yeah, the first one, marketing communication strategies. The slide that you're seeing right now, it's got various images of potential solutions that we can utilize from a marketing point of view. I will go to the bottom left image of the gentleman here. It's written here, thank you for choosing us. We value and appreciate your time. We are excited about giving you the best vision you have ever had. First question that I have for you on this particular slide is, every time someone comes for their eye exam and you did the eye exam, you prescribed a pair of spectacles or contact lenses or whatever management solution that you came up with, when that person leaves, why is it that the next time you communicate with that person is only when you are telling them that their pair of spectacles is ready? Why can't those 7 patients or 10 patients that you saw on that particular day, why can't you then send each and every one of them a personalized message via whatever platform of communication that you utilize to say to them, you acknowledge that they're here, you appreciate that they took time out of their busy schedule to come for their appointment, and you look forward to walking this journey with them. So this is something that I suggest you can start doing in your practices. Another thing, the top left-hand image, when you go on social media, a lot of the times optometric practices are making a lot of noise on social media. They tend to promote their business. They tend to promote their promotions and their specials instead of communicating with patients who they are targeting on social media at the level at which they can connect with them. What do I mean by that? The type of information that you should be posting on social media, for example, pertaining to your patients, or the testimonies that you are getting from your patients, should be something like this. Those patients that have been very loyal to you and have been in your practice year after year, ask them for the testimonies. And when they share their testimonies, ask them if you can use their personal image. And look at what's written here. I can't leave home without my glasses. And so I made sure I have more than one pair so that I'm always looking fabulous wherever I go. The pair of spectacles that you are prescribing, it has to solve an important problem beyond vision for that particular person. Patients don't just come to you because of an eye problem. You need to ask yourself, how is it that this person's pair of spectacles that you are prescribing is going to influence their lifestyle, is going to influence their working environment, is going to influence everything else that they do as a result of that pair of spectacles. So make sure that the type of communication that you are utilizing or using on various platforms is as personal as this image is depicting. And the bottom right-hand corner of this lady with holding her hand to the ear, listen to your patients. The best way to listen to your patients is to probe them as much as you possibly can. When a person comes into your practice for the very first time, but they have been wearing glasses for 3 or 4 years, which they got from another practice, very, very important that you ask them questions such as, how was your experience with the pair of glasses that you are wearing right now? Where did you get it? How were you wearing that particular pair of spectacles? What were your frustrations? What did you enjoy the most about that pair of spectacles? So probe them as much as you can so that you can have the relevant information at your disposal that you will know that, okay, this person was frustrated with the fact that their glasses was delayed when they made them. This person was frustrated with the tint on the glasses, that it did not solve the problem that they had. So the information that you're getting from your patients helps you understand where you will have an opportunity to exceed expectations, to exceed the requirements that they have. So very, very important that you listen very closely to your patients. I'll move very quickly on this. So your marketing should have the following components to it. Digital and social selling strategies. What do I mean by that? The patient should be the focus. Number 2, and as the patient being the focus, stop selling your business online. Educate the patients online, educate the patients with health-related issues pertaining to their vision. Digital researching, learn to understand your target audiences. Your patients are coming from different environments, your patients are coming from different backgrounds. So when you are communicating via marketing-related tools, you have to understand that different patients will be best communicated with in a different manner. So very, very important that you learn to understand your target audience. Next, sales enablement strategies. Everything that you do regarding your marketing activities should be about generating leads. And, I think someone is saying something there. I think it was just an interruption. It's all about generating leads. And when you have an opportunity to identify where your leads are, very, very important that you immediately follow up on those leads. One thing that I've noticed with a lot of practices is that they don't follow up on leads. And the reason why they don't follow up on leads is that they don't have digital tools within the operations that enable them to generate leads or to identify where the leads are. So it's very, very important that you've got lead generators within your marketing activities. Next, communication strategies and tactics. Remember, because of different generation types, some people will prefer written communication, some will prefer visual communication, whereas others will prefer audio communication. So it's very important that the way you communicate with your audiences is specific to the different types of communication preferences that they have. Don't just use a one-size-fits-all approach to everyone, because you won't get the results that you are expecting from that one-size-fits-all approach. Next, consumer analytics. Always analyze the data that you are having from your systems, from your CRM. What do I mean by that? At the end of each week or the end of each month, you need to sit down together with your team or your leadership team and look at, guys, this is the promotions and the specials that we are running, or these are the people that we came to our practice. What can we identify is the common trend amongst the people that are coming to our practice? How many new people did we see? How did these people come to our practice? What platforms did they utilize to get to our practice? What activities are we doing that are producing more results than the other activities? Where are we dropping the ball? So you have to constantly analyze the information, analyze the data that you are having in your practice. Next, social content depth. What do I mean by that? Don't copy what the other practice is doing. You have to have your unique brand story, and your brand story has to fit in line with your patient's story. So if you are in a particular area and your clientele or your patients that are coming to your practice are of a particular caliber, you then need to ask yourself, what is the story of our individual patients? What moves, motivates, inspires the people in our community? And is our practice relevant within the community that it's serving? So your brand story is not about how great your practice is, but it's a matter of these are the needs that our patients are having in our community where our practice is located. And this is the message that we are having in communicating that brand story to the patients. Very important. Next, digital sales messaging specific to the consumer. Whatever you do with regards to marketing, it's all about connecting. So it's a waste of time always communicating without connecting. And the only way to connect is to listen to your consumers. Listen very well to them. And lastly here, consumers needs to be, or patients needs to be engaged and not given sales pitches. And so the minute you find yourself having to sell something, as opposed to saying, patient, this is what you came in complaining of, this is what our examination procedures has revealed, and these are the management solutions that we are highly recommending to you. This is what you will experience when you go with what we're recommending. This is what you will experience if you don't go with what we're recommending. And here's is what we would best advise you to go with, and this is the reason why. That was not a sales pitch. That was clear instructions to the patient in terms of this is how life is without what you are recommending, that being that particular pair of spectacles, and this is what life will be like. So even if you're selling multiple pairs of spectacles, including contact lenses, sunglasses, whatever, each and every single part of that component for the management has to have a specific point of reference that you are connecting it with, and not just say, we've got a promotion, buy one, get one free, and you're just communicating that with the patient. Don't sell stuff like that, or don't sales pitch a patient like that. You need to make sure that you are communicating with them at the level at which you are solving their problem. And marketing can be very overwhelming. So if you don't have a team or someone in your practice that is dedicated towards marketing activities, then make sure that you are working with a company that understand what your vision is for your practice, that will be able to handle your marketing activities, because it's not a by the way thing. Yesterday we had a webinar on one of our platforms, and one of the doctors there, Dr. Joseph, he said something very powerful. He said that 20 to 30% of their revenue goes towards marketing related activities. Because at the end of the day, it's not about just retaining the patients that are in the practice, but you want to make sure that you are constantly, day after day, attracting new patients to the practice. All right, so a question that you might have for me right now would be, Obi, where do we start? Break it down into 5 components. Your marketing strategy, which will have those components to it, your product and services marketing, which will have those components to it, your sales enablement component, your client intimacy, and elevating your brand equity. And at the end, we can go into more detail if you have any questions pertaining to this slide. But this is how you can get started in breaking apart your marketing in these 5 different blocks. And we can touch base on this a bit later. All right, so I'll just summarize this quickly. The ultimate objective of any marketing strategy you decide to employ in your business is that it needs to be patient-centric, aligned with your business vision, representative of your company values, authentic and unique to your specific target audience. And it has to, at the end of the day, be strategically positioned to drive sales revenue up and user-friendly to both the practice and the patient and the patients and the practice. So don't be all over the place. Be clear on what is it that you want to achieve, so that when you are clear on what is it that you want to achieve, your marketing activities then will be measurable and very practical in how you implement them. So that's just an example of the ultimate objective of your marketing strategies. All right, I'll go through this part very quickly, and it's all about content. The past year, a lot of people have obviously migrated towards being online, and a lot of people don't know what is it that they need to be doing when they are online. And so I'll provide you with practical strategies with regards to your content that you need to be aware of. And the first one is, let me put this one. Your content involves the following components to it. There's your social media content, website, media releases, your blogs, your videos, your presentations. And so you need to dedicate enough time. We spend a lot of time on social media, but what we do, we've got a content development day where we know that, okay, for this month, we want to publish or produce 5 videos. So what we will do with the team, we will record 10 videos all at once in one sitting. And we know that these 10 videos will last us for 2 months as opposed to the 5 that we need. And we will then prepare the scripts, prepare the details pertaining to these 10 videos that we want to do. What will we be talking about? Who are we focusing on in these 10 videos? Then with the blogs, we know that some people prefer written communication. So the stuff that we're doing with our blogs would be different from the stuff that we're doing with our videos, would be different from the stuff that we're doing from our social media. So each and every single component of our content has got a specific target audience that we have in mind, because we know that when we go online, some people are going to respond to what we're doing on social media. Some people are going to respond with what we're doing on our YouTube. Some people are going to respond with what we are saying on our newsletter. So it has to have different components to it, but that is all connected. Next, over and above that content, it needs to be authentic, relevant, customized to the specific target audience that you have in mind. It has to be patient focused and break it up to your market segment. So if you are in a high-end practice and all that you are seeing is high-end patients, then your content will be specific to that market segment. But if you've got an even spread of low-income earners, middle-income earners, and high-end income or high incoming earners, then you need to ensure that your content is split in those 3 components so that you can communicate effectively with the different target audiences. All right, next, target audience. This is going to be very, very interesting. Here's the thing about our patients. Our patients have different goals, right? Each and every single patient that walks into our practices has a specific goal that they have. Some people have a health-related problem pertaining to their eyes. It might be discomfort, it might be dry eye, it might be pain, it might be headaches, whatever it is, that could be a goal. Others spend lots of hours in front of computers. Others are struggling to see when they're driving. Others are interested in contact lenses. Others are interested in just coming and getting their annual eye exams. Whatever goal, others don't want glasses or contact lenses. They want to have surgery so that they don't wear glasses. So whatever goal patients have, it's vital that you as a practice are sitting down and going to get through you need to basically train your team on how to identify patient goals. Because when you know what the patient goals are, you then know what this person requires. And if you know what this person requires, you'll be in a better position than to know where the opportunity is to exceed those expectations. And so once you have identified the particular goal, what should then happen? Number one, you need to express an understanding of the pain and frustration of that particular goal that person has. And so empathy comes into effect. We've got this whole thing of being so quick to get to the retail part. So a person comes, says, I'm struggling to see at night. You do a quick examination and you are so quick to sell them the pair of spectacles. And then 2 years later or a year later, that person does not come back, or they end up wearing that particular pair of spectacles longer than they were supposed to. The best way to communicate that you have identified what the goal is to have empathy, express an understanding of that pain and frustration, and communicate with them that, you know what, you have complained about the following, and from what we have seen in our practice with the different types of patients that come to ours with a similar goal than you, is that these are the type of frustrations that they are experiencing as a result of what you are saying. Are you experiencing the same thing? The patient is going to say, yes, I actually go through that as well. So that already establishes that trust relationship between patient and doctor. The patient then is in a position to say, oh, okay, this guy is, or this doctor or this lady is not quick to just sell me a pair of spectacles. They are clear and they understand how frustrated I am. Next, like I said, an expression of empathy in the dilemma the patient faces leads them to trust you. And that's what we want. The quicker we can get people to trust us, the easier it becomes for them to go with whatever we recommend as a solution to their problem. So always remember that your job is to show empathy. That leads to trust. Trust leads them to go with whatever that you recommend. Next, remember that at the end of the day, patients want to be seen, heard, and understood. So no patient is going to come to you and talk about multiple pairs of spectacles. No patient is going to come to you and talk about sunglasses, contact lenses. Your management solutions involves multiple management options, right? So when you're communicating with a patient, and you need to train your team to do this as well, that once a patient says, this is at the beginning of the examination, when a person says, this is what I'm struggling with, at that point that you've already shown them that you understand what they're frustrated with, automatically then lay the foundation of what the potential management solutions will be from the start, so that it's not a surprise to them at the end of the examination when you tell them that the solution to their problem will involve 2 pairs of spectacles. The one pair will have this because they're going to use this pair of spectacles during these times. The second pair is going to have these coatings and is going to be used for these activities. Then we're going to introduce a pair of sunglasses, because this pair of sunglasses is going to have this tint on it and it's going to help you with this particular activity. And then the reason why we're recommending contact lenses to you is that the contact lenses are going to come and solve this particular problem. So let's continue with the eye examination, and we will see how or whether each and every one of these management solutions that I've outlined fits into your problem or not. And if not, we will cancel it. But if it is, then we will go back and say, look, we spoke about this in the beginning, and this is what the examination results has revealed. So you need to understand that at the end of the day, you're working in a retail environment, a clinical environment, as well as a educational environment. And all 3 of those components need to work cohesively and effectively with one another in order for us to provide the best care for our patients. Next, once you've identified the internal problems, you have to constantly reassure them that you understand what they're going through and you are here to solve that problem. Don't be so focused on getting them to have that particular pair of spectacles. I will keep reiterating that point. Show them that you understand what they're going through. Tell them about the potential solutions. Examine their eyes. Reaffirm that you are here to help them solve their problem, and then go back again to the retail component of it. And then always remember, people don't care how much you know until they know how much you care. Every single patient that walks into your practice, you need to show them that you care. Every single one of them, even if they've been into your practice for a long time, they want to know. And you need to impart this in your team, because it's no point you as the optometrist or the clinician being the one who cares, but your team does not care. So train your team to show empathy. Train your team to communicate at the level at which the patient will understand, so that what happens in the exam room, as well as what happens in the front office, it's lined up with one another, so that there's no disconnection between the two. And always ask yourself, with each and every single patient that comes to your practice, what do we have in common with this particular person? And the best way to know what you're having in common is by telling stories. Storytelling is very, very powerful, in the sense that a patient comes in, says that, oh, I have got this problem, and this is how I'm experiencing my visual environment at the current point in time. Then you need to always remember patients with similar problems to your patients. And for example, a patient comes in and says, you know what, the last few months I've been spending a lot of time in front of a computer, and this is what's currently happening. You know what we have seen the past couple of months is a lot of patients are coming in to the practice with a similar problem. We actually had Mr. So-and-so come in. We gave him a pair of glasses because he did not want to go with the tint or the coating that we recommended on his pair of glasses. And he had to come back 2 months later complaining that, you know what, I'm still frustrated. And so one of the things that we are here to do is to show you that, you know what, it's not about us giving you a pair of glasses, but it's about us solving your problem so that you can experience your working environment with ease. So always relay or attach a story to your problem solving. And then, like we say, once patients are constantly persuaded that you are there for them, you have their best interest at heart, they will go with whatever that you recommend. It makes the process much, much easier. And so here's things that we have, in terms of achieving the goals, we've written here. You're guiding the patient, right? Once you have guided the patient, you're going to show them how to win. And you have to constantly show genuine care for them. Most importantly, once you have identified what the patient's needs are, be quick to deliver on what you promise will be the solution. Keep things simple. Keep things simple. And the only way to keep things simple is by having the 4 things: compassion, clarity, creativity, and competence. And this is something that the entire team needs to carry with it every single day. If you have to drill one thing into in your team's behavior mindset, is that your entire team has to have compassion, clarity, creativity, and competence. So this is very, very important for you to understand what you need to be displaying to your target audiences. All right, let me move quickly on this. Let me see if I've already touched on this slide. Yeah, this is very, very, all right. So always remember, we live in a world where everything needs to be environmentally and user-friendly, right? So always ask yourself that question with regards to your practice. Is what we are doing environmentally and user-friendly? It needs to be conveniently positioned. Before COVID-19, right? Before this terrible pandemic that has affected the world, your business was operating in a particular manner. What have you done to conveniently position your practice in patients' needs in a manner in which when they need something from your business, they can easily access it or easily get it? Have you restructured various components of your business that have made the process of getting a pair of spectacles much easier than before? Quick question for yourself to ask. And then don't treat patients as a one-size-fits-all. Make every patient feel like you are customizing the solution to them. So it's not about seeing 20 patients a day. It's a matter of the 10 patients that you've seen in that particular day. Does each and every one of them feel like you have customized the solution to them, irrespective of the level of income that they're receiving? And then next, like I said, easily accessible and available to purchase on various e-commerce platforms. So if you have not established, you might be in an environment where you say, my patients are not spending so much time on the internet and they're not utilizing online platforms. They might not be doing so right now, but a year from now, they'll be doing that. So constantly evolve your business, not for the now, but for what's going to be happening at a later stage. Think about it this way. A lot of practices delayed being online 2019, 2018, 2017. Then COVID-19 comes, and then they are forced to be online. And then by that stage, it's somehow too late. So always think about the things that you need to adjust and adapt in your practice. It's not solving your current problem. It's solving the problem that you're going to be having a year from now. All right. And like we said, it has to be practical, affordable, and most importantly, you have to always show the value. What will people be gaining if they go with what you're recommending versus what will they be losing if they go without? And that's basically what you need to be communicating with that. And then the second last part, how do you develop your unique value proposition, right? And these are 4 things that you need to be doing. You have to look at your business in this context. Now that it's a year post this pandemic, you have to ask yourself 4 questions. The first question, what in my business do I need to raise or do more of that I was not doing before? Next, what do I need to reduce in my business that is no longer beneficial to the outcomes that we want? What is it that we need to create completely from scratch that will benefit our business. Might not necessarily be now, but it will be a year from now. We will start seeing the fruits of that which we started creating. And what is it that we need to completely stop doing in our business that is actually taking us a step backwards? So you have to put these questions and discuss it with your team. Anything that you do in the business, do it together with your entire team, not in isolation. Because if it's in isolation, you won't get the buy-in of your team with regards to the implementation of the strategies that you implement. And so developing a unique value proposition involves a sales strategy approach that will be different from what you've always been doing before. And this is the recommended approach that we will have for your business. Number one, very important that in your practice, you create a welcoming atmosphere to each and every single person that walks into your practice. Whether that person that walks into your practice is walking into your practice looking unsure of whether or not they're going to be getting a pair of spectacles or not, whether they look like they don't want to be there. Your team has to make sure that with every single person that walks into the practice, you create that welcoming atmosphere for them. Next, educate. The very first thing that you need to be doing, whether you're on social media as well, whether you are on whatever platform, always be quick to educate people. A person tells you what is wrong, your job is to say, this is why you're experiencing this problem. This is what the implications of not solving that problem will be, but this is what we can do about it. Even if someone calls the practice to make an appointment to ask you to ask your team, how much does it cost to have my eyes examined? Use that opportunity to educate the patient with regards what the eye examination procedures are going to be that will be involved will be like. So you need to have sales pitches, if I can put it that way, or sales scripts, not sales pitches, sales scripts, whether it be 30-second sales scripts or 1-minute sales scripts. What are the sales scripts for a person who's making an inquiry online? What are the sales scripts for a person that is phoning the practice? What are the sales scripts for a person that is coming into the practice for an inquiry? So education is very, very important. Next, you have to, in your practice, you have to have a list of possible or potential list of expectations. In our books, we've written, like I said earlier on, we've written multiple books for the eye care industry. And in one of the books, I think it's the Business Guide for Optometrists, the second book, we outline the various kinds of expectations that patients have that walk into optometric practices. And we then show you how do you then exceed those expectations with each and every single person that comes into the practice. So it's very, very important that you learn what the expectations are and how to exceed them. So you need to do a list for yourself within the practice as an entire team. Next, always make sure that once you have educated and exceeded the expectations, you always are convincing and persuading the patient to go back to the point I made earlier on. What is the value of them going with what you're recommending versus the loss that they will experience if they're not going with what you're recommending? So convincing them and persuading them is very, very important. And if you're doing it without having educated them, it will sound like you are sales pitching them. So it's important that you first educate the patients. And next, always deliver on what you promise. If you say to your patients, this is how long the spectacles is going to take to come to your practice, make sure that you're delivering on that. The best way to lose a patient is to not deliver on what you promised them. So make sure that you are constantly on the ball with regards to delivering what you promised on. Imagine if one of the speakers ended up not being available. It was going to frustrate the Vision Science Academy today if one of the speakers was going to be unavailable and the whole preparation was done. Some of the people that are logged in were going to be very frustrated about that. So very, very important that you deliver on what you promise. And always follow up. And what do we mean by follow up? Once that person has bought their pair of spectacles, the job does not end there. You have in our second book, we've got a breakdown of how do you follow up. What do you do at 14 days? What do you do at 3 months? What do you do at 6 months? What do you do at 12 months? It's important that you know the different types of follow-up routines that you need to be doing. So the after-sales protocols are just as important as the pre-sales protocols that you have in your practice. And a lot of optometry practices, they don't have these follow-up routines within their practices, which is something that needs to change. And so where do you need to be right now within your practice? Very, very important, personalize the patient experience. I can't reiterate this any further. Personalize the experience. I already gave the example for that. Go out of your way, not to communicate with patients, but to connect with patients. When you connect with patients, it means you are communicating with them at the level at which they are understanding that you have their best interest at heart. But if you are just communicating with them and constantly telling them about how great you are, you disconnect from the patients that will potentially come and spend lots of money in your practice. Next, your entire team, you have to have product knowledge. And what do we mean by product knowledge? They need to know at a detailed level what are the product drawbacks are. When a new product from various suppliers comes into the market, your team needs to be able to communicate effectively the difference between the product that the particular patient was experiencing or using versus the new one that you are now recommending. And so if a person was wearing a particular anti-reflective coating on their previous pair of glasses for the last 6 years, and now you want to upgrade them, you will not be able to upgrade them if your entire team does not know the product information at the level at which the patient is going to be experiencing that particular product. So very, very important that you constantly have scheduled training within the practice, specifically focused on product knowledge for your team, so that when your team is communicating with your patients, they can easily, with confidence and comfortably be able to communicate what the patient will experience with the new product. And always ask for feedback. That's one thing that is very, very important, that every patient that has been, especially the ones that have been with you for a very, very long time, ask for feedback. Where can you improve your services? What can you do better? Ask for feedback, because feedback gives you necessary information that you will need to adjust whatever that you have to adjust within your practice. I mentioned this right in the beginning. Send a thank you for visiting us to every single person. If you have not started doing this, start doing it today. And if you're not online, get online. And we train a lot of people, as you saw with the images of our workshops earlier on in the presentation. We train a lot of people. Without the buy-in of the team, every single activity that you do in the practice is a complete waste. So if you are the boss, and you are just having followers in the practice, and you are not equipping your team to be leaders within your practice, all the other activities that you're doing will not be effective. So before anything, any strategy that you come in with, when you're doing that one where we said, what do you have to raise, what do you have to create, what do you have to eliminate, and what do you have to reduce? That is something that you do together with your team, not in isolation, so that you can have the feedback from your team, their opinions, their advice, and then you come up with the solutions together, so that whatever that you're implementing it was a decision that the team made, so that you can go back and say, guys, we decided this on it together as a team, but it's not working. What do we need to go back to and start doing differently? And lastly, stop making excuses. You were making excuses 2 years ago. You were making excuses 5 years ago. And now you're finding yourself in a situation whereby things need to change in your practice. So go out of your way to change that which you need to change. Stop delaying it. All right. And then the last section, operating on a high level of excellence. This is the stuff that we said you actually need in your business. Excellence should be the only acceptable solution in your practice. If whatever that you do is not focused on excellence, then you are wasting your time. And how do you then establish that there is excellence within the practice? Strong leadership leads to strong teams. So develop the leadership capacity within your practice. Strengthen the communication within our practice. You have to sit together as a team and ask yourself to say, guys, are we still communicating effectively with our patients? Is that which we are saying to our patients, whether it be on whatever method or platform that we are using, is it still effective enough to get the results that we want? So strengthen the communication within the team. Always ask yourself, what sets your business apart from any other practice? If you can't answer that, then you're going to struggle to know how do you then operate at a high level of excellence. And here's the thing about excellence. It's not even about the practice, it's about the patient. What do you want the patient to always remember about your practice, about their experience? So always focus on that which you want the patient to remember, because what the patient remembers is what the patient will tell their network, is what the patient will tell their family members, is what the patient will tell their friends, their colleagues. So if you are not creating a memorable experience of excellence for the patient will not have anything to communicate with to their peers, to their family, and so forth. Know the expectations of every patient, everyone. Oh, I think someone was just having the speaker on. Always simplify your messages. Always ensure that there's an emotional appeal to everything that you do, everything. So empathy, I keep going back to empathy because it is really the difference maker within your operations, within your activities.
Switch off. Can you please mute your microphone? I'm so sorry, Obi, for interrupting you.
No problem. These things happen, don't stress.
Yeah.
And the last thing, always cement your brand in patient minds. The best way to do that, like I said from the beginning, your brand story has to be in line with the patient story. If those two are not connected, you will miss out on so many opportunities that you can to convert first-time visitors to constant clients that will keep coming back to your practice for all their visual needs. And so in order to do that, we talk about the red carpet experience. And the red carpet experience has to do with all these things that we have listed here: service delivery excellence, patient-centric approach, value-driven solutions, strong leadership. And the whole thing about strong leadership is about accountability. In your team, learn to get to a point whereby anything that crops up in the practice that requires immediate attention, let the most senior person in the practice take the lead in that. And as a business owner, don't abdicate responsibility to your junior staff members. So there's a delay with regards to the pair of spectacles coming to the practice. Pick up the phone as the optometrist and make the call to the patient and literally take responsibility. Don't get to a point where you are blaming your staff members for things that are going wrong in the practice. The responsibility at the end of the day lies with you as the business owner. So strong leadership is so critical to that red carpet experience that you want patients to experience when they come to your practice. And be adaptable. Be adaptable. What do I mean by that? A lot of optometrists are excellent clinicians, but they are not as strong when it comes to social media, digital media, thinking outside their expertise. So adaptability requires you to say, you know what, I'm not good in this. I'm not good with training my staff on a regular basis. But wait a minute, someone else is very good at this. How can I then ensure that both myself and the team are equipped to be able to meet the needs that the practice has? And then, so another point here that we said is that you have to make sure that you go out of your way to create a working environment that brings out the best out of the team. You want your team to have that going the extra mile type of attitude. Whether a person is going to spend a lot of money in the practice or little money in the practice, you want to make your patients feel like, wow, this person is willing to go out of their way to ensure that I've got the solution that I need to solve the problem that I have. And so very, very important that you remember this red carpet experience. And in conclusion, the following training needs to immediately be taking place within your team going forward. Patient analytics, innovative communication skills, service delivery, how to clinch the deal, patient requirements and expectations, the numbers and how they affect the business, product knowledge, the management process of the patient. So you need to sit down together with your team and say, guys, when a person comes to the patient to the practice for the very first time, or for the 5th time or the 6th time. This is the process that we are following from start to finish. At each and every single point, this is where we are in a position to win the patient over or lose the patient for good. And so we need to ensure that the different departments that we are having, the different systems that we have in place of the management process from start to finish, including the after sale, is on a high standard so that we don't lose the patient. So it's constant training that needs to take place. And obviously the most important one, how does the individual team members become catalysts within their working environments? And always remember, the team is always going to operate at the level at which you as the business owner are operating at. So if you are not operating at a high level, your team will not operate at the high level. If you're operating at a very high level, your team will operate at a high level. So if you are not having regular training within your practice, break it down into these different types of monthly training. So 1 month, you could do the first one. The following month, do the next one, and so forth. If you would be interested in a structure for your training, we've got various online platforms, various training programs that we run as a company, and we are more than happy to connect with you post this event so that we can provide you with all of that information. And so, yeah, these are the books. You can order the books at visionstraight.co.za, and those are the 5 books, like I said. And please, when you finish with this event today, when you log off, make sure to connect with us on all social media platforms under Vision Straight, as well as on our personal, on my personal social media platforms under Obi Malope. It will be an absolute honor and a privilege for me to be connected with all of you, both for the personal and the business platform. And that is it. I hope everyone enjoyed that presentation, and wait until the end for the Q&A.
Thank you so much, Obi, and your presentation was amazing, and I love the customer-centric part, which, as you said, I just want to wrap it up. You have to listen to them and pay attention and make a bond with your patient and acknowledge them by sending SMS or thank you message, and of course giving a good service, as Obi just covered them all. And Obi, there is a question for you. Can you read it, or you want me to read it for you?
Let me just go up. Please read it for me.
Sure.
Oh, here's it. Do you advise a follow-up call after 4 weeks of dispensing? Staff calling to find out how they're getting along with the new prescription. So I love this question. Very, very good question. Thank you very much for asking the question. This is what we recommend. 14 days after a person has received a pair of spectacles, it's important that in your practice, you already know in advance whether or not was this person a first-time wearer of that pair of spectacles or not. If it was a first-time wearer of that pair of spectacles, remember Mr. Singh, if I'm not mistaken, mentioned the collaboration between having an ophthalmic dispensing routine, that it influences the final results in terms of how patients are going to experience the product. So if the optometrist started the process in the examination room and did the correct handover to the dispensing team, the person that can do the follow-up after 14 days is either the dispenser or the optometrist. But with first-time visitors, or first-time wearers of spectacles, very, very important that the most senior person in the practice, optometrist or dispenser, follows up. If it's a person that has always been wearing spectacles, but you have upgraded them to a new pair of spectacles with different coatings, also important for you to follow up with that particular person. If it's someone that ordered the same thing and that they've been wearing for the last few years and there was nothing that changed, and just send that thank you message for visiting us in the practice. So you need to know the type of individual that came to the practice in order to know the type of follow-up that you need to do.
Thank you, Obi. It was really nice having you today with us. Okay, and I hope you will stay with us till the end, because maybe further question will come and we need you to answer them.
Yeah, yes, no problem.
Thank you so much. And let's introduce the next speaker, Mr. Abilek Aneja. He is a senior faculty optometrist at Dr. Clark Charity Eye Hospital, and he heads the contact lens clinic there. He presented lots of papers and posters in national conferences. He was awarded as Best Paper Award in 36 AIOC in 2014. He has been into practice from last 18 years, and his main expertise areas are rose K and scleral contact lenses. He is going to talk about old wine in new bottle, which he's gonna explain what he means. Hello?
Hi. 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 Can you hear me?
Yes,
Hello.
very clear.
Great. So can you see my screen?
Yes.
Great. Thank you so much. Right. So the topic for my presentation is clear contact lenses. The reason why I called it old wine new bottle is this is basically a old concept, but this concept was basically initiated by Zakils in 1983. Basically, the initial lenses were made up of PMMAs, and later on, development of material happened, and which is taken into the more oxygen permeable category. And today we have a best material available now, like Boston XO2, Contamac, and any other and other materials available. Whereas earlier there was a PMMA lenses, then there was the limitations of oxygen supply permeability through the lens. So later on, the hole was introduced, which we called fenestrations. But because the fenestration, there was a issue of getting bubble and getting entrapped into the lens. And when it is off the visual axis, it's okay. But when the bubble moves and come to the visual axis, it creates a problem. And later on, things has developed gradually, and there is no fenestration. The material is completely sealed off and having a good oxygen supply. So the advantage of clear lenses are pre-corneal fluid reservoir. They are comfortable to wear. There's no intolerance issues like other RGPs lenses where you place the lens on the cornea and you have more lot of sensitivity issues. Since these lenses are resting on the sclera, so the comfort level is high. The stability on eye is much more higher because it's a large lens. What happens with the RGP, there's a lot of instability, displacement issues, especially in case of advanced keratoconus. When you make some little movements, you're driving the car, your chin and eyes going in opposite direction, and unfortunately the lens gets pop out. So these kind of displacement happens with the normal RGP in advanced conditions, but with the scale lenses you don't see decentration happening. See, these lenses doesn't cause any corneal scarring because there is a gap between lens and the cornea which is filled by the fluid reservoir. You fill with saline, so there is a good enough space, at least 250 to 300 micron clearance from the cornea. So there is no touch, no rubbing, no risk of scarring happens with these lenses. The reason why we are giving these lenses, you can see in the picture one, there is a irregular refraction happening because of the irregular shape of the cornea. So we need to provide a new refracting surface to provide a smooth refraction over the irregular cornea. So for that, we need to give a hard lens. If you give a soft lens, we take the same shape of the cornea. So this happens basically, the apical scarring, this is the end result of the RGP lens. You get a lot of SPKs because there is a constant touch, rubbing, scarring, and you're losing the transparency. So scleral lenses, you can see there's a vaulting over the cornea, and there's a fluid reservoir into it. Edges are resting on the cornea. The comfort level remain high. The eye remains moist all the time. They are categorized into minuscules and scleral lenses. Minuscules are from 15 to 18 mm, and large scale lenses from 18 to 25 mm. Well, I started fitting with the large scale lenses, 23 millimeter innovative scale from Hertfordshire, UK. And now we have other options available in India. We have a Boston side scale lenses also available. So the other indications for these scale lenses, they are basically for the primary, secondary aphasias, high effective errors, post-corneal transplantation, post-scarring. And especially post-corneal transplant is very difficult to fit in an RGP lens. It is very easy to fit in a keratoconic eye with other special designs, with the central punter volt and all. But with the post cornea transplantation, where you have multi-curvature cornea, it's really difficult to fit a lens. But the square lenses proves to be the best among all the category of lenses. So it provides corneal protection, symptomatic relief, severe dry eyes and ocular surface disorders, lid conditions like impression closures, trichiasis, entropion, preventing symblepharon, non-healing defects, and epithelial defects. Basically, it's a water pocket lens. It's reduce the dryness symptoms. It moists the ocular surface, and it prevents from the symblepharons. So where you have addition of lids and the conjunctiva happens because of the severe dry condition, acute condition of Stevens-Johnson syndrome. So it prevents that. So to heal a non-healing defects, you can fill with the refresh easy or other lubricating substitutes, which is kind of a novel drug delivery concept. So you can see, sorry, a lot of decentration happen with the RGP, especially when your cone is inferiorly located, and if you have too much of protrusion happen, then the popping chances are higher. So the condition like Stevens-Johnson syndromes, Tieren's margin degeneration, any kind of primary or secondary ectasia where the RGP doesn't fit well. But well, these days the scale lenses become the first choice because the comfort level is very good. It prevents scarring, it prevents from any rubbing to the cornea, and the patient also feels much comfortable. So you can see the Stevens-Johnson syndrome patient fitted with the square lens. You have to look for the compression, check for the compression. There should not be blanching of blood vessels over the sclera. So you can see there is a spot. You can easily identify it's basically corneal scar, which is induced by a RGP lens. So here you can see in the picture one, there is a good clearance of at least 250 microns between the lens and the cornea, and there is no compression on the sclera. It is the perfect example of a square fit. Conditions like congenital corneal anesthesia, where you have a recurrence of pain and redness. Basically, in these conditions, you have a loose epithelium. Patient has a blur vision, and here the recurrent episodes of epithelial defects happen because of no sensation, poor blinking, and all. So if you we have dispensed this lens to the patient, and this patient is wearing from last 3-4 years, the episodes has really dropped down. So there's no inflammation or epithelial defect happens in the last couple of years. Condition like post herpes zoster, there was a non-healing defect. This patient underwent amniotic graft membrane also, and finally we shifted into sclerals. And after 6 months, you can see the result. The cornea has become very clearer. The visual acuity has also improved from contact finger to 6/18. So condition like Tieren's marginal degeneration, where you have a superiorly actitic cornea and you have a poor stability of an RGP lens. Condition like PMCD. So here you can see in the Pentacam topography image in the right side, there is a presence of 19 depth astigmatism, which is practically difficult to fit an RGP in these kind of conditions. These kind of challenges happen even with the Roski IC. You choose a larger diameter, still you get a touch, S-lift, you do a lot of modifications, still the fitting is not satisfactory. So fit them with the full scale lenses and you get a promising results. Conditional angular forms. So here you need to be very selective to select a diameter. You can choose 14 to 16 millimeter of size. This patient we have fitted with the 14 millimeter size of minuscule contact lens. So the insertion technique is not like normal RGP lens, but in this kind of lenses, you have to place the chin down, head down parallel to the floor, clean the lens thoroughly, and fill in the saline and insert the lens. So the final fitting is like you get a full clearance. You can see there is no touch. If you see a dark area, that means there is a presence of touch. You see a full clearance. You have put a fluorescent dye into the saline and checking the fitting. So there is no blanching of blood vessels, no compression. You make the patient wait for 4-6 hours. You get a very good promising results. If there is a compression in the haptic area, then probably we need to loosen it. With the Boston side scales, there's a possibility to do sectoral modification. If suppose, let's say at 6 o'clock, there is a compression happening, you can make the haptic looser. So condition like corneal transplantation, you can see there is a good clearance, there is no compression. Wow. So this is another case of intact where this patient and visual acuity improved from county finger 3 meter to 636, but the chief complaint of patient was that he was seeing every letter was stretched, like E was looking like a L-shaped stretch E. So the rehabilitation was done with the square lenses, and the final vision improved to Silver 6. So there are a lot of cases we have done for the post-refractive surgery cases as well, fitting with the square lenses. So the take-home message is the larger diameter contact lenses have their resting points beyond the corneal borders are believed to be among the best vision correction option for irregular corneas. They can postpone or prevent surgical intervention as well as decrease the risk of the corneal scarring. So before attempting any surgical decisions met for the corneal surgeons, basically they should always attempt a trial of square lenses, and definitely you can avoid the surgery without intervention, get a very promising results. Thank you.
Thank you so much, Abhilek, for your presentation about scleral contact lenses. So if anyone has question, please write it down. We will just answer them at the end of the session. Thank you, Abhilek. I'm getting some problem here. Yes. Okay, let me introduce the last speaker, Mr. Jiko Gogoi. Jiko is an ocularist and anaplastologist based in Assam, India, he has presented his scientific papers and posters of oculoplasty and anaplastology at various conferences around the country. He has also conducted many workshops and CME in order to increase awareness among people and medical practitioners regarding the options of cosmetic rehabilitation available. His topic of presentation is impact of customized ocular prostheses in the management and rehabilitation of one-eye patients. Jiko, are you there with us?
Yes.
Yes. Hello.
Hi, how are you doing? Fine?
Fine. So I just give the screen to you.
Yeah, thank you so much. So a very good evening from India. So today, after listening to all the stalwarts of optometry about the different core subjects of our vision science, let us speak about something a little bit, different from the core optometry subjects. So today I'm going to speak about the customized ocular prosthesis and its impact in the management and rehabilitation of one-eye patients. Right. So we are good to start. So let's do it. So apart from the eye being giving us the gift of sight to enjoy the beautiful world, I mean the eyes are a very big communicating tool for people, like while interacting and while expressing their emotions and their expressions, eyes plays a very big role. And in nowadays COVID times, when half of our face is already covered with a mask, so we are left off with only the eyes to interact with people. So apart from vision, the eyes plays a very big role in this aspect. And again, in this aesthetic world, the facial beauty is given much importance. The first time we notice anyone, we always try to have an eye contact and look at the eye. And eyes play the most vital role in the facial beauty of a person. And so, as I already said, the first thing that we do when we meet someone is to have an eye contact. And eye contacts are very important in this aspect because it makes us win hearts in various aspects, in professional as well as in the personal view of life. So a proper eye contact should demonstrate respect, interest, appreciation, understanding, and self-confidence. So, but everything comes crashing down when the patient loses the eye. That can be because of some kind of trauma, tumor, or any kind of ocular ailment. So that can be devastating at any age, whether it's a young guy, whether he's a mature one or an elderly person. So the loss of the eye not only impacts the facial beauty of the patient, but also it affects the self-image, self-confidence, and also the self-esteem of the patient, right? So here the person doesn't feel like, facing the world. He alienates himself from the society. He doesn't participate in social events and always keeps up to himself. There are some patients which I have met in my career where they fear like having mirrors in their walls. They don't want to face. They don't want to see their reflections too. Again, losing the eye would not only affect the patient professionally also, but also the patient will be thrown out of some kind of jobs, like if there are some drivers or some kind of security personnel. So there are few jobs which are not, readily preferred for one-eyed patients, even if the patient adjusts to the monocular clues with time. So after the eye loss, the main psychological reactions are in this order. The first psychological reaction is of shock. The patient is in shock why it has happened to him, why it is him who has undergone such misfortune. The second psychological aspect reaction is anxiety. The patient is always in anxiety that how the society or how the outside world is going to accept him, or what are the questions he might have to face when he goes out. Third psychological reaction is of fear. The fear is of losing the other eye and turning totally blind. So that fear will always be in the patient's mind. Next is of anger and denial. Anger because the patient refuses to accept the fact that it has happened to him. And he also gets fed up with the stares and all the questions that he meets when he go out. Okay. And denial, the patient always try to hide himself behind dark glasses. And also I've seen some patients who try to keep a special kind of hairstyle where they hide half of the face and the eye where the facial disfigurement has happened. Next aspect is of guilt. Guilt is basically I've seen in India where people are very religious. They think that this might be because of some sin or some kind of wrongdoings they have done in their previous birth or in their previous life or in the early years of their life, why God has taken away one eye out of them. And the situations become more complex in case of pediatric patients because the parents always come to you and say that maybe we have done something wrong in our life, or maybe we have done something wrong in our previous birth, for which karma has played the role and my child has to go through this eye loss. So then the sense of guilt will always be there in this kind of patients or in the parents of such children. And the last aspect is helplessness. The patient feels helpless and thinks how he can overcome and how he can get out of the situation. So the patient who has lost the eye should be dealt very, with special care, and he should be given immediate expert advice. And the counseling should be given to him to lead a very normal life, and we should always give him the treatment options. The treatment option that I'm speaking today is about the custom designed ocular prosthesis. So first, before going to customized ocular prosthesis, first we need to see what are the different types of the artificial eye. The one artificial eye which is readily available and which is very much seen in patients wearing them is the stock eyes. The stock eyes are the ready-made eyes, and which you get in a big box, which will come in different colors and different shapes. And it's basically just a trial and hit and trial method. You pick up one eye from the box, you put it in the patient's socket, and you see how it matches. But one thing is for sure, that our stock eyes are not going to match with the other eye, and it is going to look different. And as you can see in the picture, the old lady wearing a eye which is artificial, but that's a stock eye, so it's not looking like the other eye. So what I make is the custom design prosthesis. It's made with a very high grade CME material, and it is matched with the other eye, and it is also compatible in the socket, because the material that is used in making the prosthesis is biologically inert, so it's not going to react with the tissues and the body fluids. So this fine gentleman, you can see in the picture that he came down to my clinic from France, and he was wearing a stock eye. Then he was asking for another eye which looks a little bit similar with his fellow eye. Then I advised him to go for a custom designed prosthesis, and we can see the result. He is looking much better than what he was looking before. So the custom designed prosthesis is worn over a damaged eye or an eviscerated globe. So eviscerated globe is like when the patient is suffering from painful blind eye, what we do, we try to give an incision and scoop out all the ocular contents, and then put an implant inside the socket in order to occupy the volume which is lost because of removing the eye. Then the prosthesis covers the entire surface, and it restores the natural appearance of the patient. So what should be the feature of an ideal prosthesis? The first is it should retain the shape of the defected socket. The socket shouldn't look like collapse, and it should also prevent collapse or loss of the shape of the eyelids, because mostly after removing the eye, after the eye getting eviscerated or enucleated, most commonly we see the patient undergoes ptosis. The upper eyelid, tends to fall down. So the prosthesis should lift the eyelid, and it should look natural as compared to the other eye. And it should also provide proper muscular action of the lid. The lid should interact well with the prosthesis, and it should move, right? And it should also prevent accumulation of fluid in the cavity. So the big factor comes in this is that the stock eyes are always, concave. The posterior side is always concave. So there is always a space between the posterior part of the stock eye and the surface of the socket. So that part, that free space gets, filled up with fluids, and there's the area where most of the bacteria and the fungus grows, and the socket becomes inflamed. But in case of a custom designed prosthesis, there is no gap between the posterior surface of the prosthesis and the surface of the socket, because it's made by taking the proper impression of the socket. So there is very less space for accumulation of fluid, and the patient hardly suffers from any kind of such complications. And it should also maintain the palpebral opening similar to the natural eye. The PFH, the palpebral fissure height of both the eyes, should look normal with the custom designed prosthesis inside the socket. So it should mimic the coloration and properties of the natural eye. Even I have made patients with teresiums, like if the patient is having teresium in the fellow eye. So I always ask the patient that I show him that you have got this thing in your eye, it's called teresium, should I make it in the fellow eye? And most of the patients, they said, yeah, for proper symmetry, you make the teresium in that also. And also we need to mimic the blood vessels and other arca senilis and all those aspects of the eye in the fellow eye, which we make in the prosthesis. And you should also have the gaze similar to the natural eye. You should also move with the other eye. Well, in speaking about the movements we can't expect 100% in this, because there is no extraocular muscles or any kind of thing attached to the prosthesis. But yeah, if we make a good size prosthesis after taking a very proper impression, then we can expect 60 to 70% movement as compared to the fellow eye. So who can be benefited? So first, the patient where you see is the phthisis bulbi patient, patient with ocular trauma or any kind of ocular infections or complications like glaucoma and all. They come to you, and for this kind of patient, you need to make a very ultra thin and modified posterior surface prosthesis, because in order to reduce the friction, the posterior surface of the prosthesis has to be super polished so that the patient achieves comfort while wearing it. So in these two cases, we can see that fitting with the ocular prosthesis restores the facial and disfigurement and gives better cosmesis to the patient. These cases are comparatively more complicated, like the congenital and ophthalmia and macro-ophthalmia patients, because most of the patients, because of the congenital element, the sockets fail to expand, and they turn into contracted sockets. Like in these patients, you can see in these ladies, you can see the socket is very contracted, and even the eyelids are also not well developed because of the absence of the eyeball since birth. For them, I'm going to speak in the next slide, but let's first see the results. So after 6-7 months of expanding the socket, we can achieve this kind of result, at least, which is something is better than nothing, and the patient looks more acceptable. So expanding the socket is done by the custom designed pressure conformers. So these are basically made of clear PMMA, and there's a button on the anterior side of that. So what we do, we make it in different sizes, and we start with the smallest size. We put it in the socket, and we just patch the conformer on with the help of a Meditape, and we advise the patient to wear it for at least a couple of hours every day. So, and when the particular size becomes loose and it tends to fall out, then we advise the patient to go for the next size. So there is a series of this kind of pressure conformers which we dispense to the patient, and we just ask him to keep continuing the next size until the patient can wear the largest size that we have given, and then he can come back to your clinic. So this also helps in not losing the patient to follow-ups, because the patient, when we call them very repeatedly after every weekend or so, the patient tends to fails to show up in our clinic. So better to give them a whole series and ask them to come back to you when they have been able to wear the largest size. And yeah, the patient can come in between whenever he is having any trouble putting the conformer into the socket, or any kind of complications he is facing. So, and these are by far the most easiest cases to fit. These are the post-surgical anophthalmia. These patients where the eye has been removed because of the issue of painful blind eye, or because of any kind of tumor that has developed in the eyeball. So in case of tumor, basically enucleation is done, where the entire eyeball has been removed by cutting it from the optic nerve. But in normal painful blind eye cases, evisceration is done, where only the ocular components are scooped out and sutures are made. So this fine gentleman was treated with this custom designed processes after his eye getting eviscerated. These cases of retinoblastoma are by far the most complicated ones which I have faced in my career, because it's very, first of all, it's very tough and heartbreaking to counsel the parents of the babies and the kids that we need to remove the eye in order to save the life of the child, because if the tumor reaches the brain through the optic nerve, then the tumor will get fatal. So in order to save the life of the child, we need to remove the eye. But the parents, the most concerned questions are that how the child will be able to cope up in his life, whether he'll be able to go to school, how he will be mixing up with his other friends of his age, will he be able to play, lots of questions in the mind. So in order to counsel the patient parents for enucleation of their child's eye, we need to show them, or we need to assure them of good cosmetic rehabilitations afterwards. So this fine baby, this small beautiful baby, the eye was removed because of the retinoblastoma tumor, and later the facial cosmesis was restored with the help of a custom designed prosthesis. And now, speaking about the complications which the ready-made eyes make, in this style you can see this eye. This is a stock eye which is fitted in the child's eye, and the eye definitely looks bigger, and it looks odd because the other eye is of smaller size. It has a lesser palpable fissure height, and this eye looks big, and it looks different. Apart from that, the main issue it creates is that because of the weight and the ill size of the prosthesis, you can see the lower eyelid of the patient's getting everted. The patient is having complication like a lower lid ectropion, because induced by the stock eye, because the entire weight of the prosthesis sits on the lower inferior fornix and the lower eyelid. So any ill-fitting or overly sized prosthesis will create a lot of damage in the lower eyelid part. But after the patients coming to me, I have tried to fit a smaller prosthesis with proper measurement which looks symmetrically better with the other eye, and the particular processes is putting very less weight on the lower eyelid, and so you can see there is no ectropion or lower lid laxity visible in this after getting this weighted. So speaking about some special complicated cases, the first complicated case that I face as an anaplastologist and an ocularist is of no or inadequate implant, because ideally socket has to be fitted with a implant at the time of removing the eye, because the volume loss which is done because of removing the eye has to be restored with a particular size implant. The implant are basically maybe of PMMA or silicone. They're spherical balls which are fitted inside, and then it is covered with the sclera conjunctiva, and then the sutures are placed. So it's always easier to fit a socket which is already having an implant, because then the prosthesis tends to be thinner and lighter, because you don't have to occupy all the space in the socket with the help of the prosthesis that you are designing. But yeah, cases will come to you where there will be no no implant or inadequately sized implant, because a particular size socket should have a particular size implant. But if the implant is smaller than the size of the socket, then again you need to make a very bulky prosthesis, a big prosthesis, because the sockets will be very roomy in these cases. So for that, what we have designed ultra light hollow prosthesis. You can see in here the prosthesis is floating in water because the inside part is hollow. So this prosthesis is basically planned in this kind of patients where you need to make a very big prosthesis, but at the same time it has to be lightweight, because if it is too bulky and too weighty, then again, as I have said, the patient will not be comfortable wearing it, and a lot of damage will be done in the lower eyelid portion. Same applies with patient with volume deficiency. This boy was enucleated when he was very young. The boy didn't use any kind of prosthesis till he comes to your clinic, and you see the whole part of the socket has shrunk. So again, in such cases also you need to fit this kind of specially designed prosthesis to restore the natural look or the best that we can give in these conditions. So as I was already discussing about the eyelid malpositions, so in this case also you can see the gentleman using a very bulky prosthesis, and as a whole the eyelid is getting loose and it's hanging, and the patient is facing other complications like discharge, and the socket is totally infected. In the other case also you can see the lower eyelid totally getting ectropionic, and the lower fornix is getting very shallow. The inferior fornix is getting very shallow. So with custom design, these problems are not present. You can see the gentleman's eyelid is not hanging out anymore, and in this case also he's having a better cosmesis, the other guy. A post-traumatic, where the parts of the eyelid are missing in such patients also, where the ready-made eyes are not possible to get fitted, you can get the patient fitted with a custom designed prosthesis. Okay, so moving on to the next thing is implant migration and ptosis. Sometimes after putting the implant in the socket also, mainly happens with the PMMA implants, the implants migrate from their central position, and ideally the implant should be placed centrally inside the socket. But in this lady, you can see the implant has migrated inferiorly. So in those patients, in these cases also, you need to design the prosthesis in a way so that the prosthesis remained intact and it doesn't, hangs out, or it doesn't slides out. So this is the lady, and as I was already speaking about the post evisceration and post enucleation ptosis, in this case also the lady was fitted with the custom designed prosthesis, and the ptosis was corrected with the help of it. So the story so far, I started my career as a ocularist in 2011. So these are the different numbers of patients that I had fitted all throughout these years. 2020, I was expecting to be a bit more, but all thanks to COVID, very, and I got very lesser patients in our clinics, and it is a very invasive procedure. You need to move very close to the patient for taking the impressions and matching the colors, and also so we can blame COVID for the poor turnout in 2020. And keeping track of all the patients, I've seen that most of my patients, I mean, it's a 45-55 ratio between male and female. And always I try to contact the patients after a couple of months of fitting the process. And I've seen that 308 of my female patients entered into a matrimonial alliance after COP being fitted. So there's some positive things that you hear from your patients, that you are doing something for the society, and it's really bringing a big change in the life of them. 630 patients became occupationally active. They again started earning, they started taking jobs, and they started moving out of their home and started mixing with the society. And the biggest aspect is that many of my patients has restarted their education. Some of them stopped going to college and schools after meeting with this eye loss, and after the cosmetic rehabilitation of the processes, they started their education. So these are some good aspects that you keep hearing, and that gives me emotional comfort. So what next? After practicing ocular history for a couple of years, I thought that what next can be done, and then I stumbled upon anaplastology, and this is the new thing which is working big time for me these days. I'm designing the ears, nose, and orbit part and the eyelids of different patients who unfortunately loses them due to any chemical or thermal burn or any kind of tumors. So this is the case of a patient where the entire eyelids and all the ocular parts has to be removed because of the tumor, and we can see the rehabilitation done with the help of a maxillofacial prosthesis. So here I have designed the eyelids, the eyelashes, and the entire eye of the patient. Another case is of auricular prosthesis of a girl who unfortunately lost a ear because of some thermal burn, and this is the ear that I designed and I fitted it in her. So that's all, and thank you very much from me to all the optometrists all over the world for listening to me, and a big thank you to Vision Science Academy, also my alma mater, Dr. Shroff Charity Eye Hospital, and also Delhi Optometrists Association for giving me this opportunity to connect with all you guys. Have a blessed Sunday. Thank you.
Thank you so much, Abilek. You are not only giving a massive change to the patient's life.
Why it's me, Jico. Jico. Abilek already spoke for me.
Sorry. I'm just writing that, and these dogs are really annoying here. I'm so sorry. Okay. Thank you so much for your presentation and for the, what can I say, amazing job you're doing, really. One-eyed patient, they are really, they are just suppressed socially, and you're just giving them life. It's very important, very appreciating.
Sure.
Okay, thank you so much. And now let us just answer some question from Dr. Carey, if you are here with us. Somebody's asked you that how the phototherapy given, if you can just briefly explain us about the phototherapy.
Oh, yes, there are instruments. Some look just like a small light, and then the colored filters go in front of the light. Some are a longer tube, and it has slits in it where the filters of the different colors can go in. In some cases, you actually have like a paper goggle with the colored filters, and you can put that on and then look at a light source. Sometimes in sunny countries, not here in the wintertime, but we just have people go outside and sit in the sun with it. So we do it differently depending on the needs of the patient and whether it's in the office or we send it home.
Doctor.
Thank you, Dr. Carey.
No problem.
And next question for Prem sir.
Okay, yeah.
Okay. The question for you is a valuable point shared. Do you document your recommendation, and is the electronic file accessible by the sales staff in your optical shop in your hospital? This helps in saving time also.
Sorry, can you just repeat that? I think I missed the question. I was reading another question, which is from Deepak.
Okay, somebody asked, valuable point shared. Do you document your recommendation, and is the electronic file accessible by the sales staff in the optical shop in your hospital? This helps in saving time also.
Right. So yes, we emphasize a lot on that for each and every optometrist. They should be putting out their prospect after understanding from the patient about their visual need and the prescription what they're releasing, which is the online process in our hospital. And the prescription actually can be easily visible by the optical team there. So they can access for that easily. And whatever your recommendations are there on the prescription, they always try to ensure that in case of any doubt, or if the optometrist has missed out something, or if the patient has some other expectations, many times they come back to the optometrist and have a rediscussion for the final recommendations.
Thank you. And another question for you is, how is your experience with trifocal versus progressive lenses in current scenario?
In current scenario, I think it's been years now. I've not talked about trifocals at all to my patients because of the availability of the progressive range, the variability that we have, because trifocals has some limitations. One is the visibility of those demarcation lines. Many times they have that image shift, and somehow cosmetically patient is not liking that, but the progressives, yes, gives that advantage. Excuse me, am I audible? Yeah.
Yes, sir. Yes, sir.
Progressive lenses give that advantage where you don't have that demarcation of lines. Cosmetically, they definitely appears better. There's no image jump, so acceptance for the patient is much better with the progressives now. And you can have wide corridors depending upon the powers, the visual needs that patient has, and somewhere you limit those things in the trifocal. Yeah.
Thank you, sir. And another question from you is, how do you see individual optometry practice versus chain of optical stores managed by big brands and multinational companies? What are the risks for individual optometry practitioners?
Truly, if you're just sitting as an optometrist, sitting as an optician and trying to compete with the other people, I'm sure you're going to really suffer that. But if you're sitting as a clinician and you're ensuring as a clinical practice and trying to have that bond with your patients, I don't think there's any threat with these individual retailers or these wholesalers kind of people, because your patient, ultimately, actually patient look for the service. And that service, many times they'll actually miss at those kind of counters if they go. And it's not only the dispensing a glass, many times the aftercare, the refitting, the balances, for those all kind of care, patient actually love coming back to the practitioner where they have shown earlier. So it's all about what our approach is. And in fact, Obi talked a lot about it. So if we can have the tips from that in your practice, I think there should not be any threat from these kind of companies.
Thank you, sir. And last question for you is, how has COVID affected the optometry practice? Has the marketing strategy and platforms changed in current scenario? And I just lost it, yeah. And what about mobile optometry practice?
COVID as such, if I see, has affected not only the optometry practice, it's actually the overall market has got affected. And what I see is the difference where people were in the habit of like going for an annual checkup, relook for the glasses, want to change their look and all, but somewhere because the pockets have got affected severely all over the world. So patients are definitely coming now, but they were coming only when they were at the real need for consulting or for the change of their glasses. Otherwise, as such, people have actually taken care of most of the places. They were well aware about maintaining the hygiene and the care for the patient as well as for the staff. So people have done that pretty well. Even in India, I'm sure that it has been followed worldwide. with the different guidelines which has come up from the government as well as for the various, even the association. In fact, the Optometry Association has passed a lot of guidelines how to really take care for your patients in your clinic. So that way, the patient were actually confident of coming to the clinics and getting the services. But yes, a lot was depending upon the pocket. So now the market is back. I was seeing like the number of patients what we were seeing pre-COVID actually, in fact, even exceeded. Maybe there was more backlog, and now there are more patients opting for the services now again.
Thank you, sir. And two questions for Mr. Jico, if you're with us. Mr. Jico, are you here?
Yeah.
Okay.
Yeah.
Okay. Jico, you have been asked that excellent presentation. How do you match the iris? Is it custom made in a small practice? If you would like to keep a tray of ready-made prosthetic eyes, what size or parameters would you advise?
Personally, if you ask me, I will never prefer to fit a patient with a ready-made eye. Okay, because that comes with lots of frequent visits, patient giving you a call at late night asking about whether to take it out or not, because he's having lots of discharge and other issues. But yeah, there are two aspects that the person has asked about iris color. So the iris color that we match is like we get some circular buttons like disc. Those are called as corneal disc. So what we do, we paint the disc with some pigment colors. So that's a different color which basically is used in tattoos and all, body tattoos and all. So that color is painted on the disc, and what we put a drop of sterile water on top of it, so that it gives the corneal kind of curvature, and we try to hold the disc very adjacent with the fellow eye, and we try to match the shade and the color. And even for iris patterns and all, also the same procedure is used. And if any optometrist ask me that how to select a stock eye, or what are the different criteria that we need to follow to keep a trial lens box, a trial stock eye box in the clinic, then I would say it's different in different parts of the country. Like in India, you find lots of the irises are mostly dark brown, or dark brown or mid brown. You don't get different iris shades over here. So most of the population are either dark eyed or light brown eyed. So you can keep a ready-made stock box which with those kind of iris colors. And speaking about the sizes can be anything. Like in some sockets which are very roomy, because with removing the eye, the lot of the orbital fat has also to be removed in some kind of tumor. So on those sockets, the sockets will be very roomy. So you need to put a very large size stock eyes in those. And in some patients, like who is having a simple case of phthisis bulbae, so already the eye has an eye, but the socket has an eye, sorry, and but it's somewhat shrunken or disfigured. So in those patients, you need to put a very thin kind of stock eye. So thin prostheses ready-made are really rare, but yeah, always advisable to send the patient for the evisceration procedure, but because that will improve the comfort level of the patient, and later getting him fitted with a custom design, because the main thing is the posterior surface. The posterior surface, as I already said, of a stock eye is concave. So there will always be a place where the fluids will get accumulated and infections will start. So always better to custom design the posterior surface so that it adheres to the surface of the socket. That will not only ensure lesser infections, but will also give better movements.
Thank you, sir. And another question is there any kind of recent advancement for contracted socket?
Recent advancements, yeah. Lately, we have been trying to design silicone prosthesis, like it will be an ocular prosthesis, but made out of silicon. And the silicon part we will be making of a larger size, and we'll be putting it in the socket. So gradually the outward exertion of pressure of the silicon ocular prosthesis will push the orbital or walls in different directions, and will exert a pressure, and gradually the socket will expand. So this is all still in the trial procedure, because the silicon prostheses are having a rubbery kind of finish, so the comfort level will be comparatively lesser. But yeah, with continuous installation of lubricating drops, that can be achieved. So it's still in the trial procedure, and hopefully we come up with some positive results in next couple of months, I would say.
Thank you. And last question is, how often should ocular prostheses be replaced?
Ideally, I ask the patient to replace it in every 5 to 6 years. But yeah, if the fellow eye is showing some ocular manifestations, like the sclera getting yellowish, the conjunctiva getting more blood vessels, then he can always come earlier to me for getting a new eye. But yeah, but even if the patient is having no complaints, ocular prosthesis needs to be replaced every 5 to 6 years. And every 6 months the patient should come for a polishing, because however the patient might clean it, there will always be a bacteria culture going on top of the surface. So it's always better to come down to the clinic and getting it removed, cleaned, and polished once in a while.
Thank you so much, sir.
Oh.
And next question for Mr. Abilek. Abilek, can you just come on the screen?
Yes, please.
Yeah, the question is, sir, any special consideration during fitting and assessment, especially in case of severe ocular surface disorder like SJS or OCP?
Right. So according to the guidelines we follow, there should be at least 250 to 300 micron of the clearance from the cornea to the lens surface. So this was just for the apical clearance. For the compression thing, we need to basically wait for 4-6 hours and check for the lens binding or compression in the sclera, because in Stevens-Johnson syndrome the conjunctiva is also a little loose, and there are chances to have a compression as well. So you need to wait for 4-6 hours to check the compression fitting. You take out the lens after 4 to 6 hours of wearing, and you put a fluorescent dye, and then you assess the conjunctival staining. If you find the conjunctival stain is not obvious, then probably you can go ahead, and the patient is not symptomatic, there's no pain, no discomfort, then probably you can go ahead with the same kind of lens. Or in a sectoral position, you find there is a lot of staining is happening, or compression, a pool of fluid is coming over there, then probably that sector needs to be modified. So we have a software based fitting can also be done with the Boston Scale software. You can easily do a sectoral modification as much as you can. We want, like, you can say about 150 to 200 micron difference you want to create, you can do that.
Yeah, thank you so much. There are many more questions, but let me just ask you one more, then we just finish the question and answer part. Like, yeah, someone asked, can you please tell the wearing schedule for both types?
Okay, so basically for the neophyte, new wearers, we recommend to gradually increase the wearing hours. Like initial days, you make it 2, then 4, then 6, 8, 10, 12 hours in a day. We recommend 10 to 12 hours in a day, but definitely the people have a lifestyle where they want to wear for the longer hours till the late evening or late night. So then it's better to give a break in the afternoon or the evening time for half an hour. That helps really extend the comfort level till the late night.
Thank you so much for your answering. And I would like to invite Prem sir for giving us the conclusion note.
Well, thank you, everyone. And I must thank all the speakers today. I know it's not easy at all to take out time from your busy schedule, prepare that content, bring out all your expertise and experience into those slides to make the audience get from that. So really thanks, Dr. Kathy, for a wonderful presentation. Obi, I really loved your presentation. I know I might disturb you again and again to have your more talks. Jiko, I really loved your presentation, and all my colleagues from Shroff, Abhilek and Sonia, really all the hard work that you've done, it was very visible from your presentations, the kind of efforts you have put in to bring that stuff over these slides. Thank you very much. And I must thanks Soumya for all the efforts in wonderful coordination, making all the things to be so smooth line and having all under control. I know it was a little delayed, fine, but I think we all were enjoying the talks, so even audience didn't mind waiting for that. So it was really nice to have everybody on this platform. And of course, I can thank Vision Science Academy, who has made all of us to be on this platform today. Without their support, actually, it was not possible. And of course, our Ocular Interface, the sponsor, to bring all, because otherwise we have a limitation in the Zoom. So they actually supported us for that, as well as the certification and other activities. Without their support, a lot of things may not have gone the way we have planned, and we are able to achieve them. And of course, my own body, the DOA president, Mr. Tyagi, I know he has always been one call away from me whenever I say something needs to be done, and he's all the time ready and goes wholeheartedly to support for any of these kind of activities. So thank you, sir, for all that. And Dr. Mandal, Abhishek, really thank you. Personally, I want to thank you actually for all your support the way you have been doing for us. Thank you so much. And once again, thank you everybody, all the participants actually. I wish you all enjoyed the session, the content which we could bring on. You all really liked it, and some part of it, I'm sure you'll be able to keep and make that change into your routine. If it can really does it, and I'm sure we'll be more happy and we'll feel more successful today. So thank you for joining us today. And I must congratulate each and everyone who's there today for the World Optometry Day well in advance. I know it is on 23rd, but we planned it on 21st because of Sunday, so that we can have maximum people attending this session. That was only the reason. But well in advance, I just want to wish a very, very happy World Optometry Day to each and everyone on this platform. Thank you. Thank you once again. Thank you, everybody. And if I missed anybody, I'm really sorry about it. But yes, thank you so much, everybody, for being today with us, taking out time from your busy schedule, and particularly on Sunday. Thank you.
Thank you, sir. And I also would like to thank you from Shroff Eye Hospital, and also Anil, sir, from Delhi Optometric Association. And thanks, everyone, for joining us today for this Vision Science Academy platform. And I wish to see you soon. Have a nice day and goodbye.
Working on developing technological advancements through artificial intelligence and machine learning systems to revolutionize the eye care industry. Our AI systems will be used to support the eye care field by taking over some of the basic work to help ensure that eye care professionals can focus on providing exceptional care. To learn more, visit our website, ocularinterface.com. Many efforts have been done to interface the human eye with the machines in a seamless way, and much progress has been made in this field. Innovations like eye tracking were present as early as the 1980s, and now even more practical and advanced technologies are being integrated into this development. The introduction of smartphones and portable devices have rendered the use of this interface technology even more successful, and tremendous data is collected each day, which guarantees even further other innovations in the future. Ocular Interface, based in London, England, is a research and experimental development organization working on developing technological advancements through artificial intelligence and machine learning systems to revolutionize the eye care industry. Our AI systems will be used to support the eye care field by taking over some of the basic work to help ensure that eye care professionals can focus on providing exceptional care. To learn more, visit our website, ocularinterface.com.